Sudhir has come all the way, and Dr. Prashant. We are so honored to be hosting you here. Lot of gratitude to Dr. G.S. Dhami, Dr. Rana, and above all, our mentor, Dr. Dinesh Garg, for organizing this big event and for all the guidance that they gave. We'll start without further ado on the session number 1 for this function, Retina for the general ophthalmologist. I would request Dr. Dinesh Garg, he is here. Dr. Sumit Chopra is also here. And Dr. Gurvinder Kaur to kindly chair this session. Our first speaker on preoperative dilated fundus examination, is it necessary, is Dr. Kamaljeet. Please come up. Thank you so much. There's just one small request before we start. Please, if all our speakers would stick to the stipulated time, because there is, as Dr. Neeraj mentioned on the group, function that's supposed to start after we end at 4 o'clock. So we'll all be very grateful to you. Okay.
Good morning, everyone. First of all, I would like to thank Ludhiana Ophthalmic Society for giving me this opportunity to present on this platform. I shall be discussing the importance of preoperative dilated fundus examination. Fundus exam is an integral part of ocular evaluation. The aim of this talk is to provide the guidelines as to perform cataract and refractive surgery, keeping in mind the vitreoretinal status of the patient, and the goal is to have a happy and a satisfied patient. The importance of fundus exam is that we want to avoid visual surprises. We can prevent the retinal detachment, maintain visualization, choosing compatible IOLs, and sometimes we have to manage the coexisting conditions. There is difference between refractive and visual surprise. The refractive surprise refers to poor outcome due to post-op refractive error, and it can be corrected by IOL exchange or refractive surgery. Visual surprise refers to poor visual outcome due to macular problems which were not detected preoperatively. They went undiagnosed, and this cannot be corrected because macula cannot be exchanged. So sometimes pre-existing retinal conditions, they can become a complication. If they go undiagnosed, the patient will assume that the surgery has caused it. Nowadays, patients' expectations are all-time high because of the small incision, refractive cataract surgery, femtolasers, wavefront technology, intraoperative abrometry, high-end costly IOLs, and marketing strategies. They have resulted in high expectations and supervision post-op. So even after a flawless surgery and a perfect refractive outcome, we can have an unhappy patient. So basic clinical exam is very important, and of course, we have diagnostic modalities to help us. This is a patient with posterior subcapsular cataract. If we see through the central area, the details of fovea would be hazy. So we can have a look at the fovea through the paracentral area. In cases of dense nuclear sclerosis, sometimes with 90D, the media is hazy, but we can take the help of indirect ophthalmoscopy, which can detect the optic disc pallor. Sometimes we can see the collaterals of over the disc, and there are some signs of old vascular occlusions. And if the media is totally hazy, then the ultrasonography comes to our help. Then we have wide field fundus photography. It can take the images up to 200 degrees and can be used in poorly dilating pupils and in patients who refuse to get dilated, in children, and it is also for documentation purpose. These are few fundus photographs in which we can see the peripheral lattice with holes, and there is a retinal hole in the superior-temporal area. In this picture also, superiorly there is a horseshoe tear, and there are peripheral lattices. This patient had a large tear in the inferior part. So these lesions, they have to be treated before we undergo any surgical intervention. Barrage laser should be done. Preoperative OCT is a very important diagnostic tool. It can detect vitreomacular traction, some schisis, transparent epiretinal membranes, shallow CSR, age-related macular degeneration or vitelliform degeneration, diabetic macular edema. This is a patient with diabetic retinopathy, and on OCT there is vitreofoveal traction. So it needs surgical intervention. Then sometimes the patient, they can have pectal. This is a case of parafoveal telangiectasia. So patient will be having foveal atrophy or some inner lamellar macular holes. So these should be diagnosed preoperatively, otherwise there will be poor visual outcome. Subtle epiretinal membranes can be detected on OCT. The incidence of ERM is 7% in patient more than 60 years age. The incidence increases to 20% in more than 65 years. According to GAS, there are 3 grades of epiretinal membrane. Grade 0 is cellophane reflex. The patient will have good vision postoperatively. In grade 1, there is crinkled cellophane maculopathy. The patient may or may not achieve good vision. And in grade 2, there is macular pucker. So the patients need vitrectomy either before cataract surgery or after. Some surgeons, they do combined surgery, and it depends upon the comfort of the surgeon. In cases of poor visibility because of the vitreous opacities, like in this case, there is asteroid hyalosis, and we can see some intraretinal hemorrhages. OCT can be considered, and their patient is having macular edema. So proper counseling of the patient is very important. Cataract sometimes limits the retinal view for diagnosis, so it has to be removed early so that we can start the retinal treatment. The diabetic retinopathy and cataract surgery we have another talk, so I will skip these slides. Then we have autofluorescence. This patient is having drusens, and on autofluorescence there is large area of hypofluorescence seen in the macular area. So the patient is having geographic atrophy. Drusens are not actually vision limiting. So we have to perform OCT to look for any evidence of exudative AMD. And autofluorescence is performed to look for geographic atrophy. And we shouldn't interrupt anti-VEGF injection schedule because of cataract surgery. And cataract surgery can be planned midway between the 2 injections, and we should avoid implantation of multifocal IOLs in these cases. When there is no visibility of the retina, like in mature cataracts and before performing keratoplasties, we can do B-scan, and it will detect the RD, vitreous hemorrhage, or intraocular mass. Corneal surgeons, they are doing endoscopy also to look for the health of optic nerve and macula. The risk of retinal detachment is more in cases of intracap procedures, and if the capsular integrity is not maintained, if there is vitreous loss, in high-risk cases like myopes, and also after YAG laser, there is 1% increase in the risk of RD after cataract surgery. So we can avoid it by doing meticulous fundus exam. Prophylactic barrage laser should be done, and intraoperatively proper management of vitreous loss should be there. We should avoid silicone IOLs and multifocal IOLs, especially in patients with VR diseases. And as I have told you, if the patient is having VFT or macular hole or epiretinal membrane, these conditions, they can be managed. Some people do combined surgeries also. Axial length measurements to be done with optical low coherence interferometry rather than ultrasound. And ideally we should do preoperative OCT in all cases, especially in premium IOLs, and manage the expectations, especially when the retina is not healthy. And preoperative, handwritten, guarded prognosis consent should be taken. Cautious, thorough approach is appreciated by the patients, and it will result in a happy patient despite poor visual outcome. So fundus exam is an integral part of ocular evaluation, and all efforts should be made to know the status of retina before we plan cataract or refractive surgery or any ocular surgery. Thank you.
Thank you, Dr. Kamalji.
Like Dr. Dhami always says, he started his refractive surgery after he had a PR surgeon with him.
Thank you, Dr. Kamalji, for bringing out such important issues at the outset. I think dilated fundus examination is definitely an integral part of ocular examination, and definite before any intraocular procedure is to be taken up. So thanks a lot, and I think we'll go ahead with the next talk. The program was designed basically for general ophthalmologists, and it is and especially so this session, and keeping in view the issues which we have, especially dealing with patients who are diabetics and who have diabetic retinopathy. So the next talk is cataract surgery in a patient with diabetic retinopathy. So when to do it and how to proceed if we have changes before or after. Thank you. Dr. Gurvinder, please. Dr. Dhami is here. I think you want to have any comments
about good morning, everyone. Sorry, I was a little late, stuck up somewhere. I think the first thing I feel I have not done or I have not examined a patient is the guilt in me if I don't see the retina or someone sees it for me in a busy OPD. Even not the basic selling fundus cameras, what they call is non-retinalists. They cannot be affordable by all. But by the time you do the refraction, I believe you put one drop in the eye, you have finished, and the second eye is ready for examination when you finish the refraction. And even a normal person coming to you for the first time for a routine examination will not agree for a dilated fundus examination. Make him believe that your work is half done, you're paying me for nothing. This could have been done in any optometric shop. Get your refraction done till your fundus examination has been completed. Very nicely predicted. Yes, I believed that I cannot start refractive surgery without a fundus examination. That too by a VR surgeon. Because the first line I read in a FACO training program and a book by Barrett, anterior segment sees fundus like he sees the cataract. Believe me, we really don't see fundus till it's a specialist, a VR surgeon, who sees it. It's a must for all general ophthalmologists. Thank you.
Thank you, sir. And with this, I have just a small announcement. We have the proud privilege of having Dr. Sushil Kumar, who is, I think, one of the senior most eye surgeons. He is with us. He is practicing in US. Please, a few words, sir.
Well, I didn't plan on speaking today. I just requested Dinesh to let me come to the meeting, and I've come here after 17 years, and I'm just amazed how much advanced the ophthalmology has become in Ludhiana. Because when I was in Ludhiana, there were only 2 or 3 ophthalmologists in private practice. And thank you very much for giving me the privilege of coming here. Thank you very much.
Thanks. Dr. Gurvinder, please.
Good morning, everyone. So I'll stand here because of my height problems. So cataract surgery, I'm going to talk about cataract surgery in diabetic retinopathy. So nowadays, everybody knows that diabetics are 2 to 5 times more prone to develop cataracts, and that too at an early stage. And diabetic retinopathy keeps increasing with age. So by the time a person is, a particular age group is there, so the diabetic retinopathy and cataract is going to coexist. And we all know that cataract surgery leads to progression of diabetic retinopathy and diabetic macular edema. So before we plan a patient for cataract surgery and that patient is a diabetic patient, there are a few points which we need to ponder upon. So I'm not going into the pathophysiology, but the hyperglycemia, it leads to a myopic shift in the eye. So if the patient has fluctuating blood sugar levels, so the refractive status of the eye keeps fluctuating. And also the fluctuating blood sugar levels leads to changes in the corneal topography. So these two things, the axial length and the corneal topography, is very important when we calculate the IOLs. So these can actually lead to surprises and errors in our assessment. So before we plan a cataract surgery, a good glycemic control is important. So the timing of cataract surgery, usually in diabetic patients, plan an early cataract when you can see the fundus. So the visual outcome in these cases is better. The visual outcome reduces when the cataract obscures the visualization of the retina. You can't assess whether there is diabetic retinopathy or diabetic macular edema. So there are a few preoperative considerations very important nowadays. Good glycemic control cannot be overstressed, and there should be no ocular or periocular infections that we do in all the cases. But in diabetic patients, there are few organisms which are more prevalent in the cul-de-sac. So a proper ocular and periocular infection control, especially give preoperative antibiotics for 2 to 3 days, which nowadays sometimes we are not giving. So a detailed ophthalmic examination is very important, and in this we include the best corrected visual acuity. Look for RAPD, look for the corneal health, look for whether there is any neovascularization of the iris. These are common things. You would be thinking why I'm saying that, but sometimes what happens is when we look at the cataract, we are so overwhelmed with the cataract that we don't see these things. So NVI, NVG, that is look for neovascularization in the angles if the patient is diabetic. A good tonometry, a gonioscopy, dilated fundus exam to see for any grade of diabetic retinopathy or macular edema. And if required, go for OCT, B-scan or FFA. So it's very well known now that a pre-existing proliferative diabetic retinopathy and a pre-existing diabetic macular edema will progress after cataract surgery. So even an uneventful phacoemulsification with IOL implantation leads to increase in VEGFs, interleukins, cytokines, inflammatory mediators, and these levels take almost 1 month to decline post-op. So it is very important that we reduce the incidence of these things and we manage the PDR and diabetic macular edema beforehand. And the progression is more or less related to a poor glycemic control. So a good glycemic control is very important. If we have a pre-existing PDR, we look at the fundus, there is PDR. Before doing cataract surgery, we should reduce the PDR. So PRP can be done. If the lens opacification is so much that you can't see the fundus, so immediately after cataract surgery within 1 month, do a fundus exam and plan a PRP within 1 week of cataract surgery. Some people, if you have a dense vitreous hemorrhage or a TRD, then a combined cataract surgery with vitreoretinal surgery and endo laser can be planned. In case of pre-existing diabetic macular edema progresses in almost 50% of the cases. It will progress after surgery, so treat it before we go for cataract surgery. So preoperatively, you can give anti-VEGFs. Nowadays, that's the main treatment for DMEs. We can give preoperative and postoperative NSAIDs. Nipafenec is very commonly used. And some people also, they plan both cataract surgery and intraoperative anti-VEGF injections. Look for NVIs, they are very important. If you have NVI and you plan a phacoemulsification, we are calling for a disaster. So look for NVIs. If you have NVG, treat them before, and once they regress, we can do a phacoemulsification with vitrectomy combined or with a trabeculectomy combined. So these were pre-operative. There are few intraoperative problems a diabetic patient can pose. So the main, always remember, uncomplicated phacoemulsification with intraocular lens is the mainstay for a good visual prognosis later on. So the problems which we can have is there is the diabetic patients are more prone to anterior capsular phimosis. So aim for a larger capsular axis in diabetic patients. There is poor pupillary dilatation. Everybody knows that diabetics, the pupil sometimes don't dilate. So iris hooks or expanders can be used. As far as IOLs is concerned, go for a larger diameter optic IOL, about 6 millimeters or more, so that later on the retina surgeons or the other surgeons are able to see the fundus and treat the problems. Also, there is increased risk of endothelial cell loss in diabetics, so we can go for more cohesive viscoelastics. Iris claw lenses are a no-no. So no anterior iris claw lens, no posterior iris claw lens, because one, it increases the endothelial cell loss. Second, it leads to cystoid macular edema. Third, later on, dilatation becomes a problem. Also, always keep in mind, any complication is a problem for progression. Even a longer duration of surgery leads to progression of diabetic retinopathy. So choice of IOLs, one I already told, go for a larger optic intraocular lens. Avoid multifocals and accommodative intraocular lenses, just because these will hinder the visualization for the retina surgeons later on. And avoid iris claw lenses. Rather than saying avoid, there is no need to put an iris claw lens in case of diabetic patients. Diabetic patients also, they are more prone to develop the PCOS, posterior capsular opacification. So hydrophobic acrylic IOLs are preferred. Also, hydrophobic acrylic IOLs, they have lesser propensity for the silicone oil adhesion. So later on for vitreoretinal surgeries and oil, if you have to put silicone oil, hydrophobic acrylic IOLs are preferred. Post-operatively, if we were not able to see the retina in case of diabetic patients before surgery because of the higher grade of the cataract, plan an immediate fundus exam within 1 week of cataract surgery and treat if there is PDR or CME is there. Also, remember, diabetic patients are more prone to corneal epithelial defects, corneal erosions, endothelial cell loss. There is delayed recovery for corneal edema. There is more inflammation, so you may have to give more steroids and NSAIDs. There is more inflammation leading to synechia, iritis, increase in intraocular pressure post-op, and obviously a high risk of post-operative endophthalmitis. So just keep all these things in mind when we plan a post-operative treatment management. Nowadays, the treatment post-operatively has drastically reduced. The antibiotics are not given, steroids are minimally given. But in diabetic patients, we need to follow the traditional regimes. So in case of diabetics, a better visual outcome is usually associated with, first, the preoperative management of any pre-existing PDR or diabetic macular edema. Number two, go for phacoemulsification. The smaller the incision size, better is the outcome. The shorter is the duration of the surgery, better is the outcome. Go for an uncomplicated, try and do an uncomplicated surgery. And you cannot stress it more that a good glycemic control should be very important. And when you go for a good glycemic control, just don't look at the RBS. Look for HbA1c levels, glycated hemoglobin. So my take-home message, which I want to stress is, number one, when we treat a diabetic patient for cataract surgery, before we jump onto a cataract surgery, a good glycemic control should be there. We need to pre-operatively treat diabetic retinopathy and diabetic macular edema. We need to operate before the cataract obscures the retina, and uncomplicated, a shorter duration phacoemulsification is good. Go for large diameter optic hydrophobic acrylic IOLs. Properly manage the post-op inflammation and maintain asepsis throughout. Thank you.
Thank you, Dr. Gurvinder, for bringing out all the very important points especially in cataract surgery in a diabetic patient. So thanks a lot. Any questions we have? Otherwise,
traction. So,
Yes, that's what I wanted to stress is either before or within 1 week, we at least treat diabetic retinopathy. We should not be ignorant that there is some presence of PDR is there or severe NPDR is there, or diabetic macular edema is there. So for general ophthalmologists, this session just meant do it before or in immediate post-op. That you are correct, but what you have said is 100% correct, but we should not be delaying it. Either do it before, I personally feel before is better, but that's the personal choices. But 1 week, within 1 week, we should be doing something, not forgetting about retina after doing cataract surgery.
If I have to add to it, basically when it is a case of a PDR which is warranting a vitreous surgery along with a significant cataract, we prefer to do it combined procedure. We about inject a day ahead or 2 days ahead maximum intravitreal anti-VEGF and do it combined. The chances of inflammation in a combined surgery are slightly more, not necessarily because we are doing it as a combined, but as such the diabetics always have an inflammation more. So get an opportunity taking the patient, look from the patient's perspective. Taking him to the theater every second, third day, it's not good, and that too for a major procedure. So we do it as a combined surgery, phacoemulsification with IOL implantation with complete vitreous surgery. And that does not really make. The only challenge can be sometimes in this case is a corneal edema or a mediasis, which you can now manage very well either with a viscoelastic or a scraping. Sir's comment.
I think I agree with both. I think either would work, but I think that is the way, depending on the case. Only thing, since the topic is so important, 2 things which I wanted to add here is, the biggest challenge is diabetic macular edema and cataract surgery. That is where the maximum worsening is and the patient is going to be very unhappy. So if you have diabetic macular edema and or your patient can afford, use a DEX implant, either 2 weeks, 1 or 2 weeks before or on the table. I think this has been done now all over the world. This work started somehow in our own center in PGI way back in 12 and 13. And that is must, because you will find unhappy patients more and more in diabetic macular edema. And secondly, you talked about not putting a multifocal lens only for the retinal surgeon. No, from patient's perspective. If you put in a maculopathy or a diabetic macular edema multifocal lens, his vision is going to be worse. He's going to be cursing all the time. And I have seen some of the VVIPs, those who got this kind of a lens and they had a really terrible time, and later on they want it to be removed, and in such a situation you can't. So I think few things because these are the common problems we face. So that's why I thought I'd bring out these 2 points.
thank you, sir. Thanks a lot. Thank you.
This is another thing which my retina surgeon generally says, that whenever you have to you do a good cataract surgery and then you forget to put a suture there, after 2 days when he starts operating, the wound gives way. So any patient you are suspecting that you are going to take after 3 to 4 days after doing cataract surgery, you are going in for retina surgery. So give 1 suture on the tunnel.
Excellent presentation, Dr. Gurvinder. As a cataract surgeon, I have only one thing to say. Keep your ego away. Because Probably we have a tendency that I'm going to finish this case in 5 minutes, 6 minutes. The honor is not to the surgeon, but the bad effects are to the patient. In all dioptics, if you lower your parameters, means your flow rate, your power, your inflow, and your movements during phacoemulsification, it will avoid all the structural damages, tissue touch, and minimum inflammation. So understand that what you started as a phacoemulsification surgeon as a low parameters, means flow rate less, vacuum less, power less, works best in situations which are worst. That is the point I have to put as a cataract surgeon.
Thank you, sir. Thank you, sir, for your points of wisdom. So we'll go on to the next speaker, crisis management for anterior segment surgeons, by none other than Dr. Sudhir. He is, I would say, high volume cataract and VR surgeon, and I think alone he handles a large part of retina in whole of Himachal. He comes from Palampur, although he belongs to us. He is a graduate from Amritsar and postgraduate from Ludhiana, and now settled in Palampur for last almost 20 years.
20 years.
Yeah. So he has a vast experience in dealing with anterior segment complications as well as vitreous surgeries. So crisis management for anterior segment surgeons.
Very good morning to all, and at the outset I would like to thank Dr. Dinesh sir and Dr. Nitin sir for the invitation. I think my work has been made easy by Dr. Dhami sir by saying this, that keep your ego away. For the anterior segment surgeons, mainly if we see, there are mainly 3 situations where crises arise and there is a lot of panic all around by the cataract surgeons. First is once we have a drop nucleus, drop IOL, and a dreaded complication, endophthalmitis, and you do have other minor complications which I'll discuss in my presentation. So coming to the first thing, which is a drop nucleus, most of you know that it is either the part of the nucleus or the whole nucleus goes down into the vitreous cavity. Incidence, fortunately, is going down day by day because we have a much better cataract surgeon now all around. There are definitely risk factors involved, like a pseudoexfoliation, mature or a hypermature cataracts, trauma. If it is a previous vitrectomized eyes, posterior polar cataracts, and maybe a crowded, in a hypermetropic patient, a crowded anterior segment, or in a myopic, you have a thin PC. Intraop, while you are operating, you can have a tear. You could have the tear with the lens nuclear fragment as such, or with the probe, or with the different instruments, or if you have a pre-existing zonular dialysis. So I will be coming to basically the management part, that how should we manage such cases. Utmost important for an anterior segment surgeon is to recognize that a PC tear has occurred. Because here the problem arises, because the surgeon is not able to recognize the PC tear and he keeps on manipulating, and then you land up in problem. But if you are able to recognize at an early stage, then is the time when you can control it. So early recognition, and if there is no vitreous loss, then I think that is the best time one can manage such cases. Coming to scenarios, different scenarios, if you have a small nuclear fragment still sitting in the PC, in the anterior segment, but you see the tear, there is a PC tear, but there is no vitreous. So you can deliver such small pieces through the wound itself. Or you can, as a posterior segment surgeon, I am a lot of fond of cutters. So you can use the cutter if the nucleus is moderately hard even, then also you can use the cutter and just eat it off. But if you have a very large piece in the anterior segment, then is the point when we are stuck up. So best is to just be aware that there is no vitreous, you can go ahead with your phaco, control your parameters. You have low turbulence in the interior segment, so that vitreous should not come into the interior segment, and you can reasonably do the phaco with the control of your parameters, and avoid going towards the posterior where there is a tear. But if there is a vitreous, then what to do? Then you should not proceed at all. Go ahead, take the cutter, remove the vitreous, and then you can plan your phaco. Again, you have to be careful. Once vitreous come into the interior segment, that means if we are going inside, we are going to hydrate the vitreous, and more vitreous will come into the interior segment. Then is the problem arises. So you should be very careful. I'll show you the video also to do the bimanual anterior vitrectomy, how you can go ahead with the vitrectomies. Then if the nucleus has dropped, so at that time we should stop. I think we should not manipulate. That is the time to, I think the surgery should be taken over by the VR surgeon. If you have in-house VR surgeon, better call him and get the surgery done in the same sitting itself. But if you don't have a VR surgeon, nothing to panic about. Just close your wound, do good anterior vitrectomy. IOL implantation is optional, whether you want or you don't want, it is an optional. As Dr. Rana has pointed out, close the wound with the suture. So you close the wound and then refer to your VR colleague. So I will just show you a few videos. This is the bimanual anterior vitrectomy which is being done. You don't need to put this port. This patient had a drop, so I had to go in also. Otherwise, just go ahead with the bimanual, the cutter. Just see where the vitreous is, remove the vitreous, and then you can plan the IOL implantation subsequently. This was another case where there was a drop nucleus. Nucleus was sitting in the mid-vitreous cavity, and you could see this being eaten up by the cutter itself, and cutter does do reasonably well. If you go back to the same video, we use this cutter as such to even aspirate the cortical matter as well as cutting the vitreous all around. Once the nucleus is on the retina, you need to cut it free from the vitreous all around, and then only introduce the phacofragmatome. Because if you don't clear the vitreous all around the drop part, then you can land up in problem with the use of phacofragment. I think the IOL part will be covered by the next speaker, so I will not go into the details. This was the PC IOL which was implanted, and in this case an iris retrofixation was done with a single technique. So next comes to if we don't manage these cases well, so what is going to happen? If we don't manage them well, you will have the patient with the increased IOP with the secondary glaucomas. You can have a uveitis, you can have corneal edema, detachment, and CME. So manage these patients well, and be assured these patients will have 6/6 visions if they are managed well. So I'll share one case. This patient was recently referred to us. You could see a lot of cortex all around. There was all cortex. This cortex was full. The vitreous cavity was full with the cortex, but fortunately there was no nucleus. This patient had a high IOP. The patient came to us, it was around 50s. In spite of the maximum medication, pressure did not come down. So we have to take up this patient for the surgery. So vitrectomy, the fragments were cleared. Although sometimes these patients don't have so much inflammation with the cortical matter as such. But in few patients, we do see a lot of reaction and inflammation. So you could see pre-op, the vision was around 660 somewhere, and day 1 and day 7. So patient come back to almost 6/6. So this was the part of a drop nucleus. So next comes the drop IOL. This is another scenario. Once most of the VR colleagues get referral, there is a panic all around, during the surgery, if the IOL gets dropped, most of you get calls, ki sir drop ho gaya, what has to be done? So nothing, it is not an emergency, like a drop nucleus or a drop cortical matters or these, it is an emergency. You should handle them as early as possible. But a drop IOL is not an emergency. You can wait a bit. Once the cornea is clear, then you can refer. But again, it is a matter of choice. If your VR surgeon is in-house, you can go ahead with the surgery in the same sitting as such. So I think my time is over. I'll just try to wind up. So this is one of the patients with the drop IOL. In this case also it is important that we clear the vitreous all around the IOL, and then only we should proceed further, because this is the basic thing. So in drop IOL, just keep the words, it's not an emergency, you can wait and then subsequently refer once the cornea is clear, then send to your VR colleagues to manage such cases. Another dreaded complication, I think it will be covered by the next speaker, endophthalmitis. So in endophthalmitis, important is the diagnostic part. Because most of the time what happens that we are not able to diagnose it as an endophthalmitis. We just confuse it between endophthalmitis and TAS, which is a toxic reaction. Usually TAS presents immediately. That is, next day you have a high IOP and patient comes with lot of pain. If you are able to see or you do a B scan, there is no vitreous reaction or hardly any vitreous exudate. And TAS responds very well to topical antibiotics. But if you are in doubt, it is better, get your consultation done, do refer to a VR surgeon. If required, you are sure it is an endophthalmitis, give the intravitreal. I will not go into much detail because this will be covered by the next speaker. Last, I will just show another case, interesting case, which came to me almost a month back. This patient was operated. You could see this at some institution elsewhere. You could see this SICS wound was there and lot of vitreous hemorrhage all around. So we do see such type of cases where there is a lot of manipulation by the anterior segment surgeon, and while manipulating with the iris, there is tickling of the this blood into the vitreous posterior segment, and you get vitreous hemorrhage. So this patient came to us with non-improvement of vision in spite of getting the cataract surgery done. So I think this is the stage we have to be very careful for the anterior segment surgeon. Once there is a bleeding, you have to stop the bleeding and then proceed for the surgery rather than let it tickle into the posterior segment. You see this is just in the interior, in the mid and the interior vitreous cavity. Hardly there was any blood in the posterior vitreous cavity. And once we just removed it from the interior vitreous and the mid, we were able to visualize the retina and the things were absolutely fine. So this was the pre-op and day one vision. So I would just like to conclude by saying that complications do happen in best of hands and best of setups. Surgeons who don't get complications are those who don't operate. At the time of crisis, there is no need to have panic. There is no need to keep ego, and be honest to the patient and win the patient confidence. Thank you very much, and I invite you all to the Palampur. This is our institution, and at the backdrop you could see the snow-clad Dauladhar range. Thank you so much.
Thank you for such a nice presentation, sir. Any questions or comments?
First of all, Dr. Lee, welcome.
Thank you, sir.
And we accept your invitation. excellent way of showing a complication, but I believe it's very important to win the confidence of the patient. Once you have occurred, you should know when to stop. And next question is when to tell the patient what is next. Don't lose your patience. Tell the patient that it happens, it has happened, and my colleague or we will do it at a second stage. Now most of us fear that we have not implanted the IOL. If you have dropped a nucleus, have cleaned the anterior chamber, you go ahead with the sulcus implantation of the IOL. Your job is half done to the patient that we have given you an IOL, but the rest will be done by the VR surgeon. So all depends on your ego and your patience, and you will never lose a patient for that. You have done good for him. Thank you very much.
I will ask another question that what do you think whether anterior segment surgeon should implant an IOL once the nucleus is dropped or not? Or he should leave it AFIC?
I think it is a matter of choice of the anterior segment surgeon. I don't mind even if patient is referred to me with the lens in place or not, because initially we had a problem once when we never had the phaco-frag. Now with the phaco-frag, it doesn't matter to us because in any case we have to go behind from the pars plana and we will remove the nucleus. Initially we used to deliver the nucleus like a spear. We used to fix it and deliver it. Then was the time we used to avoid the IOL implantation, and we used to ask the anterior colleagues that kindly don't. But at the present era, I would say it is a matter of choice of the anterior segment surgeon. If they want to put, I think they can place.
Like grade 5 then also?
Doesn't matter. Phaco-frag does dramatically well. The only thing is you need to have a high grade like grade 4, 5. You need around 100 power, and the phaco-frag does in the same. Only the risk becomes high because then that piece might go back and just touch the retina, and then you can land up in problem. Otherwise, I am not in a problem even if a grade 4 or 5 comes with the nucleus with the lens in place.
Yes, Dr. Sudhir, just a small little comment. You have done a fantastic presentation. Secondly, I just wanted to say that if there's a PCR and you have managed most of the cortex and a little piece or maybe even a bigger fragment is in the AC, you can very well go ahead and implant in the sulcus and then deal with the fragment. It's not very difficult.
I agree. Like a scaffold, you just put it and you have a safer. I think that is one of the best ways we can manage those cases.
I'll just add to it that I do a similar thing if I have to do an IOL exchange. I put the IOL which I want to implant first and then remove the second IOL. It's like a piggyback kind of a thing.
I think it is a matter of choice and the comfort of the surgeon, whosoever is the operating surgeon.
Thank you. So the next speaker is Dr. Vartika Anand, and she'll be speaking on acute post-operative endophthalmitis prevention and treatment.
Good morning, everyone. Today, on behalf of Dr. Balbir Khan, I am going to present acute post-op endophthalmitis. Endophthalmitis, it is such a dreaded complication. Suppose one day you have done a nice surgery and next day the patient came to you with certain symptoms. So kind of a nightmare for a surgeon, operating surgeon. So endophthalmitis, it can be after post-phacoemulsification, any kind of cataract surgery, post-trabeculectomy, post-SOR, silicone oil removal, or it can happen after post-pterygium also. So here I'm going to present few cases which has been referred to us and they have got operated somewhere else. So as you can see, this is a case. He came to us 3 days after surgery. The patient, as told by the operating surgeon, initially on the day 1, the patient was fine. But when the patient came to us, he had sudden decrease in vision. Vision acuity, it came down to hand movements close to face. There was a severe pain, 3 to 4 cells in the AC, and as you can see, there is a hypopyon also. Similarly, the case 2 also have more or less the symptoms are the same, but there is a thick hypopyon, membrane, and DM folds, which you can easily appreciate in this case. Fundus globe was very hazily seen. In third case also, the vision dropped to say counting finger, hypopyon was there, membrane, and marked corneal edema, and the patient came with severe pain. This is the case. Just yesterday we came across with this case. This also got somewhere operated on 17th of February, and yesterday only we have come across with this case. Now coming to how we are going to manage these cases. In these patients, intravitreal antibiotics, vancomycin and ceftazidime combined with dexamethasone was planned. Aqueous tab, vitreous tab was done and sent for gram and KOH mounting and for cultures. Along with that, we put the patient on topical as well as oral steroids and the atropine eye drops just to relieve the pain. So here is small video which I want to show how we used to give the it's not coming. So how generally if the patient is coming to you in IOPD with the endophthalmitis, you can give either intravitreal in the septic OT or in the OPD only. I have included one video, but I think it's not working. But so depending upon, you have to take the intravitreal. We used to give intravitreal on the 2 different sides, one on the temporal side and one on the nasal side. If now coming the, if the coming videos So if sorry, the video has not been played. I'm sorry. Yeah, this is. So if the exudates, they have been removed properly and the vision, it has improved, then there is no need to repeat the intravitreal injections. But if there are still exudates and the vision is not coming back to normal or improving, then we have to go for the vitrectomy. Now, before vitrectomy, as the fibrin is there, so you have to remove the fibrin from AC with McPherson forceps. Suture the corneal wound, because why it is very important when you are going inside, as already mentioned, the eyeball should be taut, and as the eyeball is very soft, so don't hesitate to put 6 mm cannula. Here it is a case, again we are showing a vitrectomy. We used to do 23 or 25 gauge vitrectomy. One cannula is for the infusion, another is for the light pipe, and one is for the cutter. You remove as much as vitreous, as much as exudates as possible, so that you can give a better vision to the patients. Along with that, we used to inject intravitreal injection post-operatively. So clear as vitreous as much as possible. We don't prefer to induce PVD in the first sitting. No SOI and no IOL removal. If the patient comes to normal, then it is okay. So here is the case, the same case, first one which I have shown. This is 2 weeks after PPV, and here the vision recovered to 612, 618. Thank you.
Thank you, Dr. Vartika. Any comments or questions? I think
think a good presentation, but most important comment would be that whenever you have post-op inflammation, you have to think of endophthalmitis until proven otherwise.
Until proven otherwise, yeah, definitely.
That
definitely.
is the most important thing.
Definitely.
We often call it TAS, and then we, it can happen. We have differential points, but preferably treat on lines of endophthalmitis. And
Yes.
intravitreal antibiotics are usually safe. So if you give a dose on the first day itself, makes a huge difference. Maximum amount of multiplication happens within the first 24 hours. And nowadays, since cataract surgery is done under topical, you can actually see the patient. If you've done surgery in the morning, you can review the patient in the evening, make sure everything is okay. And so that is also, these are few things which you can very easily incorporate in your practice. And intravitreal antibiotics, only thing you must remember is the dose, because little bit change in dose, that precipitation of the drug can happen, which can cause a problem. So those things, if you remember, and may have a chart ready with you all the time in the OPD or wherever you have to inject, so that all the personnel should be very sure of the dose of the antibiotic.
Yes, definitely. Okay. Thank you.
Very good presentation. At times we feel guilty, blame ourselves for endophthalmitis. Recently we had a case referred to higher center, and believe me, the cause was the eye drops the patient was carrying with him. He didn't know how they changed, but his all antibiotic bottle and the steroid bottle were highly ineffective. So many times the fault is definitely not with you, or the guilt should not be carried on, but see that it is referred to the right person where everything can be done very fast. Thank you.
The next talk will be on intravitreal antibiotics, when, where and how, by Dr. Rajwinder Kaur.
नहीं लैपटॉप तो नहीं है ये Good morning, everyone. Thank you, Ludhiana Ophthalmological Society, Dr. Nathan Batra sir, Dr. Dinesh sir, for giving the opportunity. So my topic is intravitreal antibiotics, when, where and how. So grateful for the mentors. What I know today is because of them. And the dream of every surgeon, as already told by Dr. Vartika, round central pupil, vision 6/6, good glow. Wants to see each of our patients a happy patient. But endophthalmitis, and then we go panic. We go panicky. And endophthalmitis is the inflammation of the internal layers of the eye resulting from an intraocular colonization. So the incidence has decreased from 1% to 0.05% to 0.01%. So here we are interested regarding the post-operative endophthalmitis. So first of all, we can try how to save eyes and how we can prevent.
So prevention can be done if we have, the patient has some local infection, NLD blockage, or Dr. Gurvinder has already told that treat it with topical antibiotics, or if needed, oral antibiotics also. And never compromise on the good quality fluids. Betadine in sec for 3 minutes. Good wound construction and suture when in doubt. Use of intracameral antibiotics if you have cam surgeries and you are operating a large volume operating surgeon. So these are the red flag signs. Unhappy patient, pain, poor recovery, or the sudden rapid diminution of vision, poor fundus glow. So these things are already covered. I won't go into details of these. So role of ultrasonography is very important. It is mandatory to undertake ultrasound sonography before instituting any form of invasive diagnostic therapeutic intervention. And it is a legal document for you to save yourself also. So acute post-operative endophthalmitis. So these few things are important. Is it virulent or a non-virulent organism? Differential the diagnosis of acute post-operative endophthalmitis and common organism causing acute post-operative endophthalmitis and initial treatment. So when we want to differentiate between these two, virulent and non-virulent, we have to ask ourselves these questions. Onset within 2 days of surgery, initial visual acuity, and the loss of red reflex, corneal infiltrate, pupillary involvement, and the cataract wound complications. So, and the other thing is ring infiltration of the cornea in endophthalmitis. When the patient has that is immune mechanism, you will see a clear space and initial stromal involvement, and it usually is treated with the steroids. And when it is infective, there is no clear space, and full thickness involvement is there, and the antibiotics they need. So it is a clinical pearl to differentiate between the two. The presence of hypopion in isolation does not rule out or in for a highly virulent organisms causing acute postoperative endophthalmitis. So when it is virulent, we have to differentiate because the patient will need the aggressive treatment. So the prolonged course is to be there. Multiple interventions can be needed. So the guarded visual prognosis has to be explained. So what is the clinical spectrum which can help us in diagnosing these? So when it is fulminant, that is, a patient will come in less than 4 days. Gram-negative bacteria, very virulent. Streptococcus and Staph aureus. Acute 5 to 7 days. Staph epidermidis and fungi rarely. And it is chronic, it means delayed entry and delayed onset. The fungi is the most common. So the key issues are delay in diagnosis and delay in appropriate treatment. And we are not going to accept that our patient is going into endophthalmitis. So the differential is from TAS is very important at this stage. So that is better to treat earlier. So differentiate from the TAS and endophthalmitis. So Dr. Sudhir has already told that in TAS there is a limbus to limbus corneal haze. And patient will come in, that is within 24 hours to you. And the treatment is the steroids. And in endophthalmitis may take 3 to 7 days. And the intravitreal antibiotics and the other treatment is to be done. So we can see here in this picture, we can see the white eye comparatively, the clear cornea, and the only 1 mm hypopion. So it means this is just the start or the less virulent organism is there. So the patient was treated and patient improved to 6/6 with steroids, topical steroids and oral steroids. So hypopion disappeared. So the more virulent, that is a 70-year-old male, within the first day of operation, you can see the height of the hypopion, the fibrin in the pupillary area. So it is a virulent organism. So this is a picture because he was diabetic and his RBS levels were high, so he was given intravitreal drugs on the first day, and after 48 the injection was repeated, and we can see how the intravitreal drugs act. So this is the post-op vitrectomy picture. So now the differential diagnosis is the increased post-operative inflammation, flare-up of uncontrolled uveitis, endogenous endophthalmitis, and phacolytic and traumatic cataract. Initial treatment of is the सबसे पहले, that is the counseling of the patient, and he has to be explained regarding the good visual outcome, the multiple interventions required, and primary surgery is not for visual recovery, it is to control the infection and risk of phthisis bulbi and so symptomatic ophthalmia. You have to counsel patient and you have to take him in confidence. So intravitreal antibiotics, they are the mainstay. So you have to start the treatment. So the core vitrectomy is to debulk the vitreous of infection when view permits. And until then, what can be done? It is the intravitreal drugs which can do wonders. So always and always inject before sending to VR surgeon. It will save the eyes. When, what, and how. So when to give? Earlier the better, and the moment you feel that it is worsening. And what is the ideal antibiotic for intravitreal injections? It is important to give empirical antibiotics in all cases. And how to decide? So this is the chart which all ophthalmologists should have in their OTs. So the empirical, that is vancomycin, all in cases, on the first appearance, the answer is yes. Vancomycin will cover the gram-positive, and that is ceftazidime usually cover the gram-negative. So the first choice, vanco, gram-positive, vanco, and in the gram-negative is ceftazidime. How to give? That is, as these days, many surgeons are giving intravitreal drugs, so they can give. So intravitreal drugs injection in separate syringe, preferably in OT, and vitreous biopsy best should be done by VR surgeon. And vitreous aspirate, try, but do not be so desperate to take the more of the volume. And aquaparacentesis can be taken. Sequential injections, slowly inject, rotate the plunger. Preferably 30 gauge needle is to be used. Keep the needle towards the surgeon and inject into the midvitreous cavity. So the vancomycin, that is in 500 milligram, that is 5 ml of the sterile water, take 0.1 ml and then make it 1 ml and then inject 0.1 ml of the drug. And then in the ceftazidime, then if it is 250 milligram vial, that is inject 0.1 ml and then again dilute, distill water to make it to 0.2 volume and then discard 0.1 and inject 2.5, that is the 2.5 milligram of the drug. So it is the all things you need in this case. So the clinical response, when you have to see the patient every 12 hours, improvement within 40 years should be visible, reaction, and decreased of the hypopion, decreased vitreous exudates. So when to repeat, you can repeat. If you are seeing that the patient is responding, you can repeat after 48 hours. And if there is no response, then go for vitrectomy. So, and you can also change your drugs according to the culture report, sensitivity pattern, and clinical response. And inject to intravitreal, and that is steroids. Steroids limit the ocular damage and reduces the exudation. Where does the intravitreal antifungals? When the patient is not responding to empirical treatment and vitreous biopsy culture shows the fungal element. And post-operatively, we usually treat the tablet Ciplox and topically with the fortified antibiotics. That is, tablet Ciplox can be given 1000 BD for 7 to 10 days, and steroids. And take-home message is intravitreal drugs are the first aid in case of endophthalmitis. Early intervention can save the eyes. And always inject before sending the patient to higher center. Except anyone can have endophthalmitis. Thank you.
Dr. Rajwinder,
Thank you, Doctor.
Any questions?
I think we'll go to the next talk.
Yeah. So I'll just announce we have Dr. Pavan Puneet here with a very interesting title, Management of Subluxated Toric Multifocal IOLs and Aphakia, Simple, Ingenious and Indigenous Ways. Before that, I would just like to inform to the House, Dr. Abjinder Kaur, the PMC representative, is here with us today, and we are just getting your certificate signed.
Thank you so much. A very good morning to all of you till he connects. And on this beautiful and welcoming Sunday morning, we are discussing the most unwelcome states of the scenarios of the anterior segment surgeries, and I am hereby to present one more. And to enjoy the rainbow, first we're going to put up in the rain. Thank you, Ludhiana Ophthalmic Society, Dr. Dinesh sir and Dr. Nitin for the talk. And we welcome you, Prashant sir, ardent fan of your zeal and hard work, and that's still persistent.
Just to mention, Dr. Puneet has a special technique of SFIUL, which is, that video has been published in one of those American Academy videos, 1-minute videos, I think, isn't it? Yeah. So we'll see all that today.
Coming to the presentation, and it's a privilege to present your work in front of your teacher, Dr. Dogra sir, who always taught us that the secret of any crisis management is not good versus bad, but preventing the bad from getting the worse. And I tried to keep my presentation in the form of videos so that I can skip the time. Volume नहीं बढ़ा इसमें. Volume क्यों नहीं आपकी? अब देखो. कोई सेटिंग करो. It's taking more time. Volume का है. लगी है, चेक करो. Yes.
With due respect to our teachers in ophthalmology, we hereby present simple, ingenious and indigenous ways to deal with various complications of cataract surgery, that is, aphakia management by Malhotra's indigenous SFIL technique and subluxated IOLs by fixed through junction technique. There is a saying in Sanskrit, Tavad sarvam kushlam, yavad vignam na avapanoti, meaning everything is fine until it's not.
ठीक चल रहा था, बंद हो रहा है. चलने दो, मैं टच करता रहूँगा. ठीक है, वैसे चलने दो. चला दो इसमें. वैसे ही चलने दो, ठीक चल रहा था. इसको हटा दो.
Metaphorically imagining situation being akin to this. Coming to aphakia management first, we hereby present an indigenous and cost-effective technique of sutureless scleral fixation with advantage of not requiring any microforceps, any glue, has no risk of haptic exposure, no hydrophilic IOL used, obviously no suture, and can be performed through 3.2 mm clear corneal incision too. Center of the cornea and adjacent limbus marked accordingly. localized peritomy performed.
There's some issues with the video here actually.
Infusion source applied, one can use an AC maintainer too. Scleral pockets fashioned parallel to limbus with right-sided directed inferiorly and left-sided superiorly to haptics direction. 1.5 mm marks applied at the entry of pockets. A bend 26G needle with a small segment of 246 bend prepared. 3.2 mm clear corneal entry made. One can use a holder folder forceps, injector, or a simple curve tying forceps to fold and deliver the IOL. Bend 26G needle entered at 1.5 mm mark and brought out, taking care not to pierce any iris or corneal tissue. Haptic threaded for 26G needle followed by IOL delivery. Haptic brought out and retained there with the aid of silicone bent segment, awaiting need of assistant to hold that. Similar procedure is performed on the other side.
यार ये चेंज कर दो मेरा चेंज विद माइन चेंज कर दो इसे अपने वाले से चेंज कर दो I'm really sorry for the inconvenience. चेक कर लो यार आप यार हम पता नहीं मिनिमाइज नहीं हो रहा
One can use a holder folder for
आप देखोगे ये रेजोल्यूशन का क्वेश्चन नहीं है no point in resolution क्लिक करो बस दिस इज इतना जैसा चलो तो वैसे चला देगा डिस्प्ले भी नहीं आ रहा आपने प्रेजेंटेशन नहीं है प्रेजेंटेशन में प्रेजेंटेशन मोड में नहीं जाएगा अपने में लगा दो पहले वाला जल्दी कोई तुम्हारा वो नहीं होता साथ में क्या कहते हैं
silicone bent segment, awaiting the need of assistant to hold that. Similar procedure is performed on the other side. For haptic insertion, just hold the anterior sleeve of the pocket and slide therein only to save off any haptic exposure. Port is hydrated and cautery applied to oppose conjunctiva as well as the port side. Compared to other newer SFL techniques as Yamani's, there are no trailing haptic insertion issues. To Acreos, a hydrophobic lens is used. To Agarwal's technique, no glue or trained assistant for IOL injection is required. Compared to cross-knit technique, there is no risk of haptic exposure. One can use 3.2 mm clear corneal incision and no special forceps as the Abershire forceps is required for haptic insertion. To conclude, the main benefit of this technique is being cost-effective, saves of complications and restrictions of haptic manipulation in anterior chamber, self-sealing 3.2 mm clear corneal incision, and absence of any haptic exposure further adds to the benefits. Thankfully acknowledged by American Academy of Ophthalmology and termed being most commented surgical video. So far as subluxation, another unwelcomed state presenting a minimal invasive closed-eye procedure of fixing foldable intraocular lenses including toric and multifocal lenses with a sturdier support by a technique which we call fix-through junction. This is a small animation of our technique. Two partial thickness flaps were made. 10-0 Prolene suture needle is passed through the IOL haptic junction on one side. 26 gauge needle is used to guide Prolene suture out of the corneal limbus, forming a suture loop. Same maneuver was done on the other side. Limbus marked adjacent to the optic haptic junction. Localized peritomy done on both the sides. Marks applied at 1.5 mm from the limbus, followed by formation of scleral pockets of 2 by 3 mm on either side with the crescent. Iris hooks applied. Straight needle end of 10-0 Prolene suture passed under the flap at 1.5 mm, and from the opposite side, counter traction applied to pierce IOL optic haptic junction, docked into 26 G needle and brought out of the corneal limbus. Note the sweeping movement of needle to avoid piercing corneal tissue. Iris hooks removed, followed by centration of IOL back complex. Multiple alternative knots placed on either side. One can observe the knot slippage under the scleral pocket. AC wash performed. Peritomy closed. Intracameral moxifloxacin given. 90 years old with multiple systemic abnormalities for general anesthesia only at high risk, managed to gain post-op vision of 6 by 9. 27 years old software engineer with toric lens at 62 degree was refixated with the same technique to gain visual acuity of 6 by 6, and many more performed thereafter, including many multifocal lenses. Advantages are its closed eye technique, short duration, minimal invasive procedure, cost factor is less for the fixation of the same lens, and the most important, being sturdier support than just bag alone to save off cheese wiring. In the end, I would like to conclude with the saying, sometimes perseverance with the conviction for an idea is the only option we should have, just like sunset to sunrise. Thank you, everyone.
Really sorry for the inconvenience. I know.
Thank you, Dr. Puneet.
The
I
video
think we'll just have small trophies for each of the presenters. Dr. Kamalji, please.
I'll request Dr. Dhami sir, kindly come up on stage. Dr. Rana and Dr. Neeraj, if you're around, please come up on stage. We'll just go one after the other. So request my PG residents.
Dr. Kamal,
a token of appreciation from Ludhiana Ophthalmic Society for Dr. Kamaljeet. Dr. Kamaljeet, please come up on stage. Sir Dogra sir is our esteemed guest. This was from LOS. The certificates are also there. Please give Dr. Kamaljeet her certificate. After that, I request Dr. Gurvinder Kaur to please come up on stage. Dr. Sudhir. Dr. Sudhir Salotra is not here. Okay, Dr. Sudhir is not here. Till then, we will request Dr. Vartika to please come up on stage and accept on behalf of herself and Dr. Balbir also. You can keep the gift hamper for yourself, ma'am. And after Dr. Vartika, Dr. Rajwinder, kindly be ready, ma'am. Dr. Rajwinder. And Dr. Pavan, please be ready. Next will be your turn. Thank you. Ludhiana Ophthalmological Society is very, very proud. Collectively, we are going to welcome a great mentor, and as PG students, we used to call him the father of ROP. We still do. And 25 years since we have known sir and learned from him. Even in CMC, he used to come as a visiting consultant. And what I remember most about him is he always was with his indirect gear. you know, like a soldier in war with his arms. He used to have the band and the lens in his hand, and he'll be moving around like that. So those are the best memories we have of sir. Professor Mangatram Dogra, he is a former head of ophthalmology and the chief retina services at the Advanced Eye Center in PGI, Chandigarh. At present, sir is the director of retina services in Grewal Eye Institute in Chandigarh. He did his MBBS from the Government College in Shimla in the year 1977, followed by residency at PGI Chandigarh in December 1981, and then he underwent 2 years of vitreoretinal fellowship, that is from July 89 to June 1991 at the University of Maryland, a hospital in Baltimore, US. His exclusive area of patient care, teaching and research has been the vitreoretinal diseases and surgery for 35 years. Major area of work includes retinopathy of prematurity, diabetic retinopathy, and endophthalmitis. Sir has published 234 papers in peer-reviewed national and international journals. He has delivered 621 lectures in various national and international conferences, maximum being in the area of ROP, where he has delivered 252 guest lectures. Sir is also a member of the National Task Force for ROP constituted by the Ministry of Health, Government of India. He is internationally recognized as an expert on ROP and considered a pioneer of this field in India. Dr. Dogra is a former president of the following society, which is the Vitreoretinal Society of India, North Zone Ophthalmic Society, Chandigarh Ophthalmic Society, and Himachal Doctors Alumni Association. He is also the former treasurer and chairman scientific committee of the VRS. I am going to be a bit breathless now because I am going to the list of awards and honors, but I have to mention a few, sir. Sorry, I will not listen to you today. Achievement Award from the American Academy of Ophthalmology, Distinguished Service Award from the Asia Pacific Academy, Achievement Award from the Asia Pacific Academy, the Hanumanta Reddy Award for the Best Paper, L.C. Datta Award for Best Paper, J.M. Pava Award for from the Vitreoretinal Society of India, Professor B.P. Kashyap Memorial Oration, the 9th Dr. Narendra Swarup Memorial Oration, Dr. Daljit Singh Oration on ROP, gold medal from the Bombay Ophthalmological Society. He has also got the World Sight Day Oration on ROP, Award of Honor from the Himachal Mahasabha. After that, he is also a recipient of the Professor Ishwar Chandra Memorial Best Paper, the Dr. R.P. Center Oration, Dr. Mahendra Mishra Oration, Dr. Ajit Babu Maji Oration, Dr. Bazurg Barua Oration on ROP, again the Sadguru Medal in 2013, Dr. R.P. Tandon Oration, Dr. Kishnendu Sarkar Memorial Oration, Dr. S.S. Here Award, the Gonin Oration, the Dr. Narendra Taneja Oration, SSM Oration, Dr. Samir Biswas Oration, and the list goes on and on. But I will just end with that he also got he was given the first Dr. S.S. Badrinath Oration on vitreoretinal surgeries, past, present, and future. So, ladies and gentlemen, I think we need to invite Dr. Dogra on stage and give him a standing ovation for being here with us today. Thank you so much, sir.
Thank you, Dr. Nitin. You made me almost breathless. And I must thank you, Dinesh, and others here from Ludhiana Ophthalmological Society, and for giving me this opportunity to be over here in this August gathering and talking to you something which has been my journey of life. Maybe it will add something to somebody. I think Prashant is here. Maybe this may be the reason that I worked all my life in this particular field, that I was chosen for the first S.S. Badrinath oration this year, which was one of probably the best I could get ever in my life, of course, out of so many other things which were there. Yes. Well, friends, I do have some financial disclosure, but has got nothing to do with this as far as this talk is concerned. As far as my journey with Retina, I'll not go to my journey as it started with my medical education or before, because 13 years I spent in my own village, remote village. I was born in a very, very sort of a backward area. I studied in the village till my class 8. Anyway, so after I would come straight to this, I did comprehensive ophthalmology from 1981 to 89. And that time, you see, it was so different. I think we used to do most of the all things, but be interested in particular things. So that is what it worked. And that was the era, if some of the old timers are here, that we had to send, if there was a VR problem, to all the way to Chennai. You see, that is where we were. And that was the reality of life. Very few could do that. And for me, the major breakthrough came, I would say, when I got this Vitreoretinal fellowship in USA, which I did for 2 years, 80. And this was also perhaps for, I would say, for PGI, our region. We could develop Retina, which is now, of course, a history, and we know it, how well it has grown. That is where I am with the team in the University of Maryland. This is Professor Vinod Lachenball, who is, I'm there on the top, and the Mark Preslin, pediatric ophthalmologist. I think he was the man I first saw ROP in 1989. He would take me along, and he was the one who was doing, in 89, cryo, and in 90, he started doing laser, although it came much later over here. So that is where I learned. You have some of the famous Stanley Shockett here, was director of Retina. Shockett Shunt you have heard. Shockett Depressor you have heard. And this gentleman here, he used to be chief resident with a white coat. He's a very famous Jack Shoffey. If anybody is a glaucoma person, they would know it. He was the world president as well as the world-known person that time. So I think that is the way my journey is. The this is by Robert Frost. 2 roads diverged in a wood, and I took one the less traveled, and that has made all the difference. So this is exactly true for my philosophy. That I took the least traveled, and I would say that changed my life, as with the life of thousands of children I could give vision to. This became my biggest mission, passion, or obsession, and it helps to establish me, especially the ROP and Retina services in PGI Chandigarh. So basically, my journey in ROP started in 1989, as I said already, and that was the time there was no awareness, nothing. We didn't know much about ROP, because I think it used to be one paragraph in a book, retrolental fibroplasia, that was gone, just like that. So that is where we were, because these babies were not surviving. So I think this is Professor Vinod Lachenball, who was there, and I was with his team in the Retina service. Atul Kumar stayed in my apartment for 6 months in a fellowship. He also was there in Baltimore. You see, famous Stanley Chang. This is the time he demonstrated first time PFCL. And I still remember it happened in Baltimore, and everybody stood up, because those giant tears and other things stuck to the cornea. They could be settled, and it was, you can see my son Mohit, who is a Retina. He's a little child here, over there, in front of the World Trade Center, which doesn't exist. So he was just probably 7.5 years that time. I give a lot of credit to, many of you are his students, Lingam Gopal. He was my contemporary in PGI, rather 6 months my junior, he and Professor Jagatram, both of them. You see, in 90 he started doing in India, first of all. And he told me he came to Atlanta that time. You see, he's 1 year younger to me. He looks even that time. This is in 90 older to me. So I'm standing behind. And so that he started seeing some ROP. I said, I'm already seeing. He said, concentrate more. You are going to a place which has maximum number of because his neonatology chief, who was in the Trust Hospital, she was a PGI product, who was heading the neonatology or the pediatrics there. And this is subsequently, you can see Tarun also, his son, young there, when I think 95 I visited them. And this was subsequently, we were holding the course in 2000 in AIOS. And I was very lucky to be with a team. You know, first neonatal center in the country was in PGI. It has trained 70% of the neonatologists for our entire country. That is the way it is. And this is, he's known as the father, Dr. Owen Baku of neonatology in India. And Dr. Narang, with whom I got maximum associated. Downstairs, you can see now the Parveen Kumar. He's very active, and I was associated with him, as well as from RP Center. You have, I think the gentleman has retired also, so we were. And I must give credit to Professor Azad. He started, of course, he was forced to learn in Kuwait, but he came back in '94. We started that time. That's how we were only two. Harsh Kumar started before him, and he's no more in Retina or ROP. He even wrote a book. So I give him a credit, and he's gone on to glaucoma. And this is one of the workshops you see here in 2001. Look at Subhadra Jalali. They are young. Harsh is there. Of course, you can see many of them you may recognize. They are all very young here, including your madam from CMC. You can see she's behind there. And I used to come, and I did first laser for ROP when she was the head of the department there. That was in CMC. And I was very lucky that we had great role models and colleagues in PGI. I think they, especially our chief, who gave opportunity to everybody to grow, as well as always encouraged if we wanted to do something, there was nothing. Somehow this picture was taken by chance. And this was almost 29 years back. And our chief, Professor I.S. Jain, Dr. Amod Gupta, Dr. Jagatram, me, that is how we were the heads of the department also. We are sitting as if it was destined like that. I do have a Professor Sofat there who was my mentor in Simla, and you can see Dr. Garewal, young there, so many, even Professor Chopra you can see is young. So there are so many people you can see this is how it can be 30 years back. So during my entire career, 90% of the theses were on ROP. That is what I concentrated on, and dabbled into research, and encouraged that I took opportunity not only to teach, to also to learn from various people, which I'll come to. This is my first thesis candidate when I came from USA. In '92, he is Rohit Charan. He doesn't do, they have their own hospital in Jaipur. He doesn't do this now. This is the first thesis I gave, and the first thesis published back by me and Gopal in '95, and we knew the problem is similar to Western countries. And subsequently, so many other things were also published. Used to document initially with a video indirect. I have these prize pictures which were taken from me by various people from China, Vietnam, Indonesia. I think people had a problem that time. They were not having pictures of ROP taken because these are RetCam and other things that not really come. So I really feel that these pictures were shared by so many of them. And we realized that these Western guidelines are not fit for us. And there was some publication, of course, Claire Gilbert did a lot of work, and this is by Subhadra Jalali and so many other centers. And of course, this down there, I'm going to show you this. This is one of my most famous students, Anand Vinekar, who stayed 6 years with us. And this was his thesis I had given. And this has the maximum citation any paper can imagine, especially in ROP. It may have more than 150 or maybe 200 citations already. So that kind of is, for ROP, it is impossible. And so this was his work, which we published. We couldn't publish anywhere. People said we are crazy. Higher birth maybe these are fever. They don't know how to diagnose. He got so frustrated. I told him, send to Indian Journal. No, sir, this was your dream. So I said, my dream is for India and Indian Journal. So today, this is one of the best 5 ever cited papers written for Indian Journal of Ophthalmology. So that is where it is. So important, 16% of the babies are already in this 1750 grams and above, and even above 2 kgs. And that period of gestation, which was less than 30, later on they made 30 weeks, 23% were above that. So once we looked at this data, this is from Subhadra Jalali, these are 2 from us, Gaurav Sanghi, as well as this is the last candidate, to take Chandani, my thesis candidate is from us. You can see the weight where we are. Higher birth weight babies, that is where we are. You look at Japan, this Dressner, she worked with Michael Tracy, this is from her, his group. So Azuma is from the Children's Hospital in Tokyo, and you can see all these where we are, how much difference is there. So this helped us change the guideline for the entire country. So now it is 2 kgs and 34 weeks. That is the way it works for us. And in the beginning, I also started the cryo because that was one procedure approved in 1989. I did cryo from 91 to 97 under general anesthesia. I think Ravinder is here. She would remember 3 heads next day. I mean, it was a terrible procedure, I must say. And later, of course, with great difficulty, we got laser, and 97 onwards, we started that. And anti-VEGF, we started much later. We were very skeptical that there'd be, so sometimes in 2014, first injection was given. Can you imagine? This is before my superannuation, 18 or 19. In my own OPD, these 2 girls, I had done cryo. They were twins. And this is the picture taken that time. Yeah, this did pretty good job. High myopia, but vision is 6.6. And they're doing so well. I think one was doing MBA and something else. So I think it was so satisfying seeing all these people doing so well. And of course, I said diode laser. It was must before. So we procured this diode, and that's the way in 2 weeks' time we could see results. These vessels would absolutely become straightened up, and you have a good regression. And one of the procedure which, in fact, became very handy later on. This has been done. I have shown this all over the world. This has been shown in practically most of the, because this was done first time, and that was Anand there who was with me. And you see, this came during COVID time. Many people started doing this because they were, and not only that, they made contraption on this. So this got cited very well that time and came as a great help. So I thought something which has been done has proven worth. And what made us very happy, me especially, was this first, I think it was published subsequently in BGO 2010, presented as a poster in American Academy. And I was kind of, people were, oh, what are you doing? I had good pictures. I'll show you one of the pictures which is there, which I had shown with good regret. They said, no, nobody will do without a diode. No, we showed we can do it, and subsequently large series. Today, it is a standard of care. The same laser which you use for everything you have, you can use for, and this is being done now in most of the countries. So that kind of a myth which was there, this is the case I had put up on my poster that time, and you can see how well it has regressed. Another thing which we observed, because whatever, at least in my mind, was that we should do the problem which we face, are facing us, we should concentrate on that, and that is aggressive posterior ROP. I think 50 to 60% of the patients were aggressive. We published first in Retina in 2009. And it was a landmark, and it became sort of a thing where people knew it, that this is happening in higher birth weight babies. And subsequently, this in American Journal, which we published. And here, what we said, posterior zone 1, which is, most of them have an unfavorable outcome. Of course, I'll show you a study. And later on, these are the papers, I mean, which got cited very well. So this was the one which, in fact, we published in Canadian Journal, because this posterior zone 1, the one thing only, if you look down there, 79% had unfavorable outcome with laser treatment. That is what and you can see one of this case. We lasered, whole retina contracted. Posterior zone 1 means you have vessels stopping at fovea. That is what it is, posterior, making it simple for you. And you have stretch breaks, whatever the big surgeon one may be, nobody can do anything here because you can't fix this retina. And of course, documentation is according to ICROP. And why I have highlighted this, they changed aggressive ROP to replace posterior ROP on our paper. This is part of the ICROP class. They had to debate on this paper. This hybrid name was given by me. This is in BGO. They never wanted to, Anand told me he was part of that. They never wanted it a hybrid to be named. So they put everything into aggressive ROP based on this publication. So this is one which they have put there, and they even put this thing that because of this, that we see in many countries in higher birth weight, especially with a lower or limited resources, so they had to change this. So I feel very privileged that our observation and whatever we did, they have not only helped our country, but across. So these are some of the images. In fact, these were finally provided by Anand only, and these are mostly what we called that time hybrid or mixed, is now called as the aggressive ROP. I think this was the parting shot, I must say, here, and this is something, Simar is here. I love Simar. Simar is all the time, and he's pursuing this along with Diksha in the center where I was. I think one day I said, we are sacrificing too many lenses. Let's sit on the nasal side. And he was with me. I just sat on the nasal side, turned the microscope, and put the cannula, I'll show you, right in the center. And we always used to do this for quite some time. He remembered that partially we insert this and so that it doesn't go in, and there is already there where it will stop, and you stop there and just go in and cut that. That is this stop and slide, which is also published. Anyway, let me describe, even if it doesn't work. So you sit on the nasal side, put this at here, right in the center, and your endo-illuminator and vitreous scatter are on the other side. And you can accomplish all, and you will not sacrifice the lens. You see, sacrificing the lens is the biggest problem, if you have done that. So for 4B, this is the procedure. In fact, because of this procedure, I am invited. I am going to be going to Riyadh, Saudi Arabia, just on 6th. I think the gentleman, I didn't know he's the president of Saudi Society. He's inviting me, and so they have everything covered for me for this. I think this. Oh yeah, I think it's working. So this is prepared by Simar, and if it works, I think it is kind of jumping. But yeah, what you'll see here is that you put it in the center, and you know, all of you know, we put 1 or 1.25 millimeter from the limbus. We go vertically down, but the lens is globular. That is the way we go. And once we have put it in, what we do is that we didn't know, Simar knows, that it is supported by the nasal bridge. We used to have a problem on temporal side because it will hang down. So that was another advantage. It wouldn't touch the lens at all, so you are confident. And same way with that stop and this thing technique, once we have gone in, and you'll see it's fairly, in fact in this, I think, you can see the case, and that is the temporal elevation. So you would have sacrificed the lens for sure. And after we did this surgery, and what you need to do is, you remember one thing. I think Parveen is here. Parveen has extensive experience as far as the ROP surgery is concerned. We need to cut entire vitreous. We need to get rid of whatever we can comfortably do. That is the basic principle. Don't go the way we do adult surgery, that you're going to remove these membranes and you're going to be doing the same way. No, it's just not possible. Because if you create a break, that is end of the surgery. Then it is end of everything. So whatever is comfortable, you go in, keep on doing. If it is like here, I found that it might be more vascular, so we just went ahead with the cautery a little bit and then cut it. And that was almost like end of the surgery. So you see, you don't want to overdo it. Just want to be doing enough. I think after this, the case was almost over. And then we did partial air fluid exchange here. And you can see that has settled down. Now on intraoperative OCT, you can see the whole thing has come down. So you know your job is done. And that's it. That's where we have ended. I think I'll just show you so this was the result. So you can see even a case as bad as that, if coming all the way up, you can give fairly good result. And of course, I already said my philosophy was to associate as much as with people across the globe, those who had done work in this country or anywhere. Here with Michael Tracy and Anand, we are together here. You can see that in the center is Michael Chang, who is at present the director of National Eye Institute also. And I think we had visited, me and Anand, them in Columbia, Preston, New York. And here's the gentleman who has given the pathogenesis of ROP. And so these are all the pioneers. And of course, you can see a big group. I think I'm going to meet Dr. Kusaka in Riyadh. He's going to chair the same session where, along with Sengul and Sengul, they'll be there. And of course, you have a Wu who's all the time with us. I was even as a judge for the World Congress along with Michael Tracy and everybody, Michael Shapiro and Kondo from Japan. I was the only one who represented as a Asian representative in the World Congress for the big symposium they held. They've been inviting me all over. I think I was nominated just because of my work to the National Task Force. We changed the guidelines. So I did, and 22 orations I have given on ROP in India. These are all the members of National Task Force. So you do see here also Professor Azad and Subhadra, Parijat, and everybody here. Of course, Pramod is there. I became president probably because of this. It was during my presidentship. We took first international symposium to Hamburg, Germany. That is where we did first symposium. You can see everybody who's of Retina or whatever ophthalmology here that time, and it was during my, and I have 63 peer-reviewed articles on ROP and conducted various workshops, trained a lot of people. You can see here a lot of them trained. They are everywhere, all over, not only in this part of, I of course feel that they cover most of the big or smaller places across the country. And it gives me sort of so much of satisfaction. When I superannuated, they came out with a supplement which was entirely on ROP. And it is written right in the editorial that we are bringing it out when I'm retiring because I did so much of work. So it was such a big tribute for me, I couldn't imagine. And I already mentioned about this. I got this first SS Badri Inauguration. Dr. Prashant is part of that committee. And I must show you, this is my picture with him in '95. I was invited for this workshop, which they had a sort of a vitreoretina surgery. And who is sitting there? I was made to chair session with Tatsu Hirose. That is Tatsu Hirose sitting there, and I'm sitting there. Can you imagine? He was the man who did open sky vitrectomy, who was the real man who worked with Professor Vadinath in Boston. So I think that is how they used to encourage, or chief used to encourage. I was never his student. I never got that privilege. So in India, it has been bothersome. It was increasing. That little retrolateral fibroplasia went all the way to become an epidemic. More and more started becoming, and because of these heavier baby problems, we had a big problem. These kind of babies, which I used to see first once in a month, then one in a week, then I started seeing 3 to 4 in a week. This is retina behind. Nobody, not a bigger surgeon can fix this. Nothing can be done. And we did publish this. This was in ophthalmic epidemiology. I think we saw that many of them, they were not only screened. You can see, only the parents, when they subsequently realized that their child is not seeing. That is where we were. This is not long time back. This is in 2011. And how to, I think this was sort of a article written by all of us, which included not only from India, but all across, that what can be done? What can be, how can we prevent? We had to reduce the incidence through excellent neonatal care. That is where, which is first step but lacking. That's why we are with the, more and more we are onto that front. And country-specific screening guidelines, we had that changed because it was very important. And timely screening as well as their detection and treatment, that is what is required. And This was one I had given the first thesis to, and this was the thesis given subsequently to another student. So 20 years. The first thesis was the same which I showed you, which was given. This after 20 years, in our own setup, look at the incidence decreased from 47 to 22%. Although by this time, much lower birth weight we started surviving. So that is what the difference would be. If you can do that, it will make a huge difference. I made a promise to myself. I have to go if I was invited for ROP, I never refused. I went to most difficult areas, even to the areas once in Bihar, where doctors were getting kidnapped. And my wife, she protested and I went. So that was my own resolve to myself that I have to prevent this. So we have now, for their retrolental privilegia, we have a society. Can you imagine we have a society because of that? I think here is also Parveen down there, and with Boo and Subhadra. So we are all in different meetings here. I think something to do with PGI and ROP. You can see these big stalwarts sitting with me who has changed everything for ROP. They are all from PGI. They're all from PGI. We all are products of PGI, starting with me, of course, Lingam Gopal, and Subhadra, the way she is involved in this, and of course, Anand Vinekar. And I think what made the difference? I think three of us, we worked together more than 35 years. I think we remained together all the time. All students know that. I think that is what made the difference for us, and we could work in areas, whatever was possible. Of course, these are my parents, and my family supported me. So this journey continues, my friend, and I feel we should get more and more involved in this area. I can tell you, you'll do 100 phaco. Do one screening and send that baby for treatment. I'm not talking treat. You will have the biggest satisfaction of life. So that is the way I would put it, and thank you very much for patient hearing.
Dr. Dinesh, Dr. Karamjeet is here. Sir, please come up on stage. And Dr. Ravinder Malli, please, you also. On behalf of the organizing committee, we would like to honor Sir with a small token of our appreciation. Dr. Simar? पकड़ के रखो इसको सर इन लोगों ने शॉल नहीं दिया Dr. We will be having the inauguration right away. Before that, I will request the representative from Punjab Medical Council, Dr. Abjinder, to kindly come up on the stage and say a few words.
Good morning, everyone. It is a great honor for me to be here with you all, such a talented gathering. I would like to express my deepest regard and respect to Dr. M.R. Dogra, who have come from Chandigarh, and my regards to all the dignitaries present here. My sincere thanks to Dr. Nitin Batra and all the organizers of this CME for the honor I have been given here. And I am Dr. Abjinder. I did my this graduation and post-graduation from Kanpur University. Then I came to Punjab and joined the PCMS. And I served PCMS for many years. And I was nominated as a Punjab Medical Council member by the Punjab government. At present, I am executive and the ethical member of Punjab Medical Council, and I am here to grant you 4 credit hours for this CME. And I hope you all are registered with PMC. If you are not, if facing any problem for getting this registration or renewing or updating, let me know. I will help you. Okay, thanks.
Give a token of appreciation to ma'am from Ludhiana Ophthalmic Society. Ma'am. The certificates, all the delegates here are signed, but you will only get it after lunch, and we will give you lunch only at the end of the sessions. For the brief inauguration ceremony now, I request our dignitaries, first and foremost Dr. Dogra, Dr. Prashant, Dr. Sudhir is back here. He disappeared when we were giving the trophies, but sir, please join up. We must have the inauguration, so I will call the stalwarts first. All of you please come up on stage. We will just light the traditional lamp and declare the event formally open. Dr. Dinesh, Dr. Prashant, Dr. Dogra, Dr. Salotra, Dr. Rana, Dr. Neeraj, the early bird, Dr. Sarabjit, early bird, please sir. We must acknowledge your presence here today. Dr. Karamjit is here, sir, please. Pause. Ma'am, Dr. Abjinder, ma'am, please. I'll go later. was absent when the mementos were giving. So we'd like to give a token of appreciation from Ludhiana Ophthalm Society to Dr. Sudhir. Thank you so much, sir. Such a long journey, but you've been here. Thank you so much for gracing the occasion. And after that, we are just going to have a brief 15-minute refreshments break outside. Then we'll gather back again for the next two sessions. Dr. Nishat and Dr. Prashant and all, kindly, if you can just load your presentations or attach your laptops before going out on either side so that we can move much faster. Technical, these delays are, slowing down the proceedings a lot. So please, the next two speakers, if they can just have their talks on the laptops ready, we can proceed. फिर बनता नहीं है तुकना हाँ नहीं नहीं थैंक यू सो मच for being here, ma'am. Okay. You're ready? All right. We're going to start with the next session. We are almost on the road to recovery and we should make up the lost time now. This session is on intravitreal injections. It will be an 8-minute talk each, and then we'll have at the end 15 minutes panel discussion. I think the panel discussion 15 minutes at the end of the session, please. For this session, we have Dr. Rana. He's here as a chairperson. Dr. Prashant is also here. And myself, Dr. Rupali. Dr. Karamjeet, is he inside? All right, first. So our first speaker will be Dr. Nishat Bansal, safe technique of intravitreal injections. Request all the other speakers after Dr. Prashant to please keep putting and loading the the laptop here, or if you wish to attach your laptop, we can just save time. So in this session we have Dr. Nishat, then Dr. Prashant, Dr. Dinesh, Dr. Parveen, Dr. Mohit, Dr. B.S. Rana and Dr. Mayank. All of you are here. Thank you.
Should I start, sir?
So I'll be handing over the mic to Dr. Dinesh. Yes, please start, sir.
A very good morning to all. And I would like to thank the local organizing committee for this opportunity. I'll be talking about this very simple and important technique of giving intravitreal injections. So it is one of the most widely performed eye procedures worldwide nowadays. And we have many kinds of intravitreal injections, anti-VEGF, steroids, antibiotics, as we have already seen in the previous session. And there are various indications like diabetic macular edema, wet ARMD, retinal vein occlusions, even ROP. Nowadays we are giving anti-VEGF injections, but my talk won't cover ROP injections. This procedure nowadays is not only carried by the retina person, but it's also carried about by anterior segment surgeons and general ophthalmologists. Later in the day, I think we have a discussion also on this. And though the incidence is very low for the endophthalmitis, but it is a dreaded complication. And suddenly we have a lot of boom in biosimilars, so it becomes even more important now to see the procedure, how we do it. So first, most important thing is the storage of the drug. It is important to procure the drug from an authorized company or a dealer with a bill. And it is very important to note the batch number of the injection before opening it. And it should be kept in a hospital refrigerator. We have a dedicated refrigerator with a temperature over it, and we keep all our injections in that. And it should be preferably in a dark place with the temperature display, and power backup is must, because that cold chain has to be maintained. It should not break the cold chain, and to be kept under lock and key so that that fridge doesn't be opened each and every time. So a written and well-informed consent is very important before doing the procedure. These consents are available with so we can avoid the injection on that day. And it's important to verify the patient name and eye to be injected if there are multiple patients in a similar day, and proper OT dress is required. And topical povidone iodine, 5% in the conjunctival sac 2 to 3 times at a gap of 10 minutes is to be put in the patient in the pre-op area. So the contact time of at least 3 minutes is very important. This single step is very important, which has reduced the incidence of endophthalmitis post-injection. And we have to clean the face with the 10% povidone iodine. During the procedure, the injection has to be performed under sterile OT conditions. It is not an OPD procedure, and proper surgical scrub, as we do it for the anterior segment surgery, cataract surgery, retina surgery, it has to be done in a similar way. There is no shortcut in this. And cap covering the nose and mouth is must, gloves are must, and very important not to talk during the procedure. And eye drape is also must. The lid speculum has to be put in nicely to avoid the eyelashes coming out from it, and preferably to give the injection under microscope, though indirect can also be used for the injection according to the preference. And any quadrant according to the surgeon preference can be done 3 to 4 mm from the limbus. If we are giving Ozurdex or Triamcinolone, it is better to be preferred in the inferior quadrants. And this is a short video of my place, how I carry the procedure. First, we check the BP and the sugar of the patient in the OPD. Only if things are under control, then the patient is shifted to ward. If the BP or sugar is high, the patient is not taken up in the ward during that day. A consent is taken. Then the patient is shifted to the ward, and proper OT dress with the marking of the eyes done. This step is very important. We put a paracaine and betadine around 2 to 3 times, as I've already discussed. Proper scrubbing, proper OT scrubbing is done, and proper OT dress. There are few things which are mandatory on the trolley which is required. You need an artery forceps to clean the face with the betadine. Scissors are required to cut the drape. Calipers is very important to mark the area and distance from the limbus, speculum, few buds, gauge pieces, 10% betadine solution, 1 ml syringe, 26 gauge needle or a filter needle. Sometimes the filter needle is provided with the injections, a 30 gauge needle, and an eye drape. How we prepare the injection? We gently shake the injection before opening it against the light so to see for any suspended particles or any change in the color. So if any change in color is there, we don't use that injection. After opening the injection, we just put a drop of sterilium. It can also be wiped with the alcohol swab. And just clean the rubber cork with the buds. Without injecting any air in the vial, directly the injection is pulled. And remove the excess air and bring it to the mark of adequate dose which is required to be injected. The eyelashes are cleaned with a bud, face is cleaned with a 10% betadine. An eye drape is placed. I generally clean the area to be injected with the betadine, and lashes are away from the field of injection. Anesthesia soaked buds are kept, limbus is marked, and gently retract the conjunctiva and go perpendicular. Slowly the injection is given and it is removed with a bud over it so that the vitreous reflux is minimum. And put back the conjunctiva and put a drop of betadine. And in case of Ozurdex, similarly, here we have to go parallel to the limbus halfway and then perpendicular. And with a one firm clip, we just release the implant and the needle is removed in a similar direction. Post-injection instructions, patient to have a dilated examination on the day 1 and day 3 and to look for any signs of infection, and recently we've seen some injections being reported of intraocular inflammation, so that has to be seen with a dilated examination. And in case of Ozurdex, to check intraocular pressure at 1.5 months, that's very important. To avoid head bath and swimming for 3 days. And if we are planning injection in the other eye, also to keep a gap of minimum 3 to 7 days. And to report immediately in case of severe pain or redness or vision if a patient is having. The role of antibiotic is still not clear, but it can be used in case of a single-eyed patient or a patient is having allergy to betadine. And if we have an adverse reaction, it has to be reported immediately. We should note the batch number, and any patient who's given the injection on the same day, they should be called and examined. And the patient has to be referred to higher center if you don't have a VR setup, to be referred to higher center without delay, and it's always better to tell the patient what has happened. Thank you.
Dr. Nishad, please receive a token of appreciation from Dr. Rana. Is around. From Dr. Nitin Bhatt. So our next speaker is the national faculty for the program from AIUS ARC. He is the chairman academic research committee of AIUS and a good friend. Dr. Prashant Babankulle from Sarakshi Netralaya, Nagpur. And I think most of us know about him. He is a fellow from Shankar Netralaya. We were together in 94, 95. And since then, he has focused on retina, and he is, I think, doing the maximum number of vitreoretinal procedures in the whole of the Central India zone at Nagpur. And he is a very active member of AIUS, and he has transformed the ARC into a next level. bringing in so many new changes, and one of which is this program Retina for All. And we are thankful to him for giving us an opportunity to organize this program here. And he is with us, and he'll be speaking on early intensification in DME management, why it matters, and real-world experience with brolizumab. Dr. Prashant, please.
Thank you, Dr. Dinesh. Thank you for those kind words. Naturally, they come from my dear friend whom I shared my room or a flat while doing my fellowship in those days of Shankanetralaya. So before I start my presentation, I need to acknowledge few of the people who really worked hard for this program. As a chairman of an academic research committee of All India Ophthalmological Society, this program, Retina for All, was conceived by the new team of ARC. Why was it conceived? Because today, as on date, we are almost 1,400 vitreoretinal surgeons across the country. And if you look at the staggering amount of the workload which we have, if we take single disease, that is diabetic retinopathy, we have more than 70 million diabetics who need some form of a screening at least for their eyes, which cannot be managed by 1,400 odd people. Leave aside the passion of Dr. Dogra, sir, about ROP and other many more diseases, retinal diseases. And so naturally, this burden needs to be shared by our comprehensive ophthalmologist colleagues. And with this particular thought process, we have conceived this particular program. So at least the understanding of the retinal diseases, the diagnostics. The second program which ARC is conducting is diagnostics in ophthalmology, because we have seen a change in the way the diagnostics have come up into the OPD practices of ophthalmology. So our aim of ARC is that we familiarize you so that you can at least make a diagnosis and help this patient reach out to the right people who can treat it timely. Many of these smaller procedures, like for example, now most of the anti-segment surgeons do have an OCT with them, so they can help us out in reducing the burden of injections and all. If in UK and Western world, the sisters and the nurses are giving injections, why not in our country? Even for a case of an endophthalmitis, what happens when we see in our practice is that patients are referred to us even before giving a single intravitreal antibiotic injection. So by the time he lands up with the vitreoretinal surgeon, a precious time is lost, which can definitely be injected by any comprehensive ophthalmologist in any part of the country, even in the remotest place. And basically, this is the intention of this particular CME. And I'm really thankful to Ludhiana Ophthalmological Society and Punjab Ophthalmological Society for coming forward to host this particular CME in this region. My sincere most thanks to all the executives, without naming everyone who has conceived this particular program, and it has turned out to be a wonderful one. And of course, Ludhiana has been a special attraction to me. This is my probably 5th or 6th, because my dear friend who is sitting here and who was one of the advisors for this program, always there, and I love the food. The moment I stepped out of Chandigarh en route, I went in a dhaba and had a paratha. So all this attracts me to Punjab a lot. So without much now, let's move on with the further talk. This is a sponsored talk on behalf of Novartis, who is taking care of the sponsorship of this particular series of programs which we are doing in our country. So early intensification in diabetic macular edema, why it matters, and what is the real world experience of this new molecule brolizumab. As we are all aware, there is a big epidemic of diabetes which is looming over the whole world, and it has actually become the truth. And there has been a drastic increase in the percentage. If you look across the other countries, there is 33, 55%, but in Southeast Asia, where we are placed, there is a jump up of almost 74% of the population of diabetics. And disease burden, because of this in our country, you can look at the sight-threatening and the diabetic macular edema and PDR, it's almost comprising almost 58% of the diabetic population. And diabetic macular edema, though we have had multiple treatment options, way back when we started our fellowship or postgraduate days, we did not have much to offer. Then came the lasers in a big way in the 80s. Then the pharmacological agents came right from steroid. It began with steroids, then came the anti-VEGF therapy in 2012, which has revolutionized the way we can look at the disease and stop the progression of the disease. And now we have started about improvising the outcomes, or rather improvising the vision. This is since 2012. Before that, we used to only talk about holding back whatever is with us. Does it really matter to start early in the diabetic macular edema? If you look at this arise and write data, you can see that the patients in the group sham group, you will notice even when they were put about 2 years later on the anti-VEGF, could not achieve the visual gain which the patients who were initially put on, who started their treatment with a anti-VEGF molecule. And that is what it shows the importance why we need to start early treatment. Similarly, this restore and protocol therapy, again, studies also show that patients who received early anti-VEGF in the form of ranibizumab had a better visual outcome at 3 years and 5 years. And you can look at more than 70 letters gain, which was seen in 76% of the patient had an early initiation of the treatment. So similarly, early treatment with ranibizumab led to more than 75% patient achieving more than 2-step diabetic retinopathy improvement within a year. What happens if you don't treat it timely? Well, untreated macular edema results in a gradual decrease in vision, and which even if you initiate the treatment later, cannot recover back as if you you had initiated it earlier. Now coming to the real world experience, in the studies, the patients were given, enrolled patients are given monthly injections, but does it translate into real world evidence? No. If you look at even the studies, the maximum number of injections which the patients have received is 12, and the minimal is 6.6 in a sponsored, even in a study patients. While in real world status, you will see that the highest number of injection which any study has shown is 7.4 versus as less as 1.5. And coming to our Indian standards, you will see that the number of injections are even lesser. On an average, most of the patients in real world in our country end up having 2 or 3 injections. By then they get exhausted. And what happens finally if they do not receive these injections in a protocol-based manner, in a timely manner, they have a poorer outcome. So intensive treatment in ear definitely, as I said in initial slides, also leads to better and functional and anatomical outcome, and this is what the various slides shows. Now, what is the challenges if we want to achieve this real strategies which have been put across in the study is that most of the patients fail out of this treatment, as you can see from this particular slide. And in this particular slide, which shows the current status in our country, mean number of injections which patient received within a year, average was only 2.1. And we as an Indian retina specialist felt that number of injections, if we can bring down by using certain molecules which have more durability, it might help us in having a better compliance from the patient's age. And that is why we need a molecule which was, we were in a need of a molecule which had a better visual gain and resulted in number. So we had brolucizumab, which we have been using since last 4 years for AMD. And the Kestrel and Kite study is the use of this molecule. The study, they have seen whether it can be used and how helpful will it be in a management of diabetic macular edema. This is the various studies which have shown that time since the diagnosis and this, you can manage the macular edema, and early intensive treatment showed a better visual outcome in this particular patients. So I will just run through these slides. So what I wanted to say is that with this molecule compared to the previous anti-VEGF molecules, we had a better reduction of the molecule edema as well as better visual gain, and the adherence and the compliance of the patient, if the number of injections is reduced, can definitely be increased. So let us see through this few of these patients which I will share with in our setup. This is 75 years old male diabetic hypertensive. This is the at presentation CSME bilateral with a non-proliferative moderate to high risk non-proliferative diabetic retinopathy, and the OCT you can see intraretinal as well as the SRD over there. And as you can see, I will just run through it. That point we initiated this particular patient with bilateral Acentrix along with panretinal photocoagulation, and this is what 2 months post-op. You have the edema which has come down in the left eye. Right eye did not respond significantly, rather there was a back. We continued injecting this particular patient with multiple injections of Acentrix. And this is what happened, that we were continuously injecting, but somehow it would again wax and wane, and again it would be back within a month. So at this point, we had an indication approved of brolucizumab for diabetic macular edema. So we initiated the treatment, and in this, and look, within a month you can see the recovery in the right eye, which was so resistant to, this is the first thing, after 5 eccentrics and multiple injections. And this is within a month, and this is what we can. Meanwhile, the left eye also started showing edema, so we dared to continue, put the brolucizumab even in the other eye. And you can see the resolution. And in this particular right eye, which you can see, we needed a second injection only after 3 months versus the our right eye, which was needing monthly eccentrics. Now, this is case number 2. This male had received multiple anti-VEGFs in both eyes elsewhere. This is the picture, photograph, and the edema. You can see epiretinal membrane as well as edema, as while in left eye, SRD along with intraretinal edema could be noted. Fluorescein angiography, we do as a protocol, and fluorescein angiography for all cases of diabetic macular edema. We are still probably an old thought, but we would like to know the exact status. That is why we do it at our place. Patient had received multiple PRP followed by anti-VEGF, and this is what. He did not respond, and this time we had brolucizumab, and we decided to go ahead with bilateral injection of brolucizumab in both the eyes. Bilateral does not mean that we gave it on the same day. We usually give it within a gap of 2 to 3 days. And this is what you will see 1 week post-injection, about a month later. At that point, we believed in giving initially, as per the site, we were giving a loading dose. And you can see we continued giving about a monthly injections. First 3 injections were given. I will just run through this. Somehow I missed upon one of the slides. So left eye did show a resolution after 3 injections, but right eye, which had an epiretinal membrane, did not respond, so we went ahead with doing a vitrectomy in that case. This is third, 58 years female, diabetic, PRP done elsewhere, decreased vision, macular edema, you can see classically. Fluorescein angiography showed in the right eye multiple NVs in the periphery, so naturally that also needs to be taken care with the help of a thing. So this patient at that point of went ahead with fill-in laser, and 3 injections of eccentrics were given, and this is about 4 months later following that. The edema had further increased, and so at this point brolucizumab bilaterally was given for a case of a diabetic macular edema. And this is what you see within 1 day later, about 7 days later, and this is 4 months later. You can see a wonderful resolution in right eye. Left eye in 4 months had again a resurgence of edema, which we again treated further with brolucizumab. Now another case where a 51 years diabetic patient, you can see edema in both eyes, right eye more significant, angiogram. I will just run through it. And 1 year later, this is the picture. At that time, we introduced brolucizumab, and you can see as we started treating him, multiple injections, 3 injections given monthly, 5th injection, every time this edema would come back only after 8 to 10 weeks. So we had a disease-free interval of this particular patient every 3 months, 8 to 10 weeks, I should say. Another case, clinically an NPDR, and you can see minimal edema, and this was octa, where you could pick up a small new vessel. So if you have such a small new vessel without a traction, we have started treating these particular patients with brolucizumab for a case of a proliferative diabetic retinopathy with not significant traction. This is an angiogram just to show you, and we went ahead with brolucizumab, and on an octave, you can see the regression of the new vessel in this particular part in the following slides. Keep an eye. You can see this new vessel has wonderfully come down besides the edema which was responding to our brolucizumab. And this is about 2 months post brolucizumab, where I cannot show you. Yeah, this is that new vascular front, which has also means as a byproduct you are also able to treat a new vessel elsewhere, and this is how it responds. This is another case. I will just run through it. Another silent bilateral diabetic macular edema. You can see on an octave montage, you can see the new vessels and the irmas in the periphery. We went ahead with treatment of brolucizumab in this particular patient. as a primary modality of treatment. We did not wait for any other anti-VEGF. This was just as in the naive case, which we went ahead with bilateral brolucizumab. And you can see on a subsequent follow-up the response to the OCT as well as the IRMAs and the neovascular front, which were initial stage, had started responding to it. And so we continued a treatment without lasering, without doing pan-retinal photocoagulation, simply on a brolucizumab as a primary modality of treatment for a case of early PDR. So these are multiple other cases. I think I will just end up over here. So this is a wonderful molecule which helps you in giving a durability for this particular cases. So any case now in our setup, we have started using it as a primary modality of treatment and a primary molecule of choice. And in a cases of diabetic macular edema, without the fear of IOIs, which is much more hyped in Indian population, I feel. I have done more than 700, 800 procedures or more so. And in a diabetic macular edema, we have a follow-up of more than 1.5 years or so. It responds wonderfully. The most important thing for me, why I choose this molecule is not because I am here on behalf of Novartis, but basically it is pocket-friendly to my patients in my region. Because for us, if you look at it, in our centers, we charge about 7,500 rupees for an Avastin. If I have to inject 3 Avastin, it comes to 24,000. While in our center, a Pagenex injection goes for about 29,000 rupees, including a procedure cost. So in 3, and that reduces the number of visits, and in 8 weekly, if I mean, the cost economics also work out quite cheaper for a patient. So rationalizing the cost is equally important in the setting in which we are practicing, and that's why this molecule has become a molecule of choice for me, not only in AMD or venous macular edemas, but also in diabetic macular edema, as well as in early proliferative diabetic retinopathy. Thank you once more, Ludhiana Ophthalmic Society and Punjab Ophthalmic Society, for this wonderful invite and great hospitality which I had yesterday evening. Thank you.
I shall be requesting Dr. Dinesh, before you proceed on your talk, please join Dr. Dogra and Dr. Dhami in felicitating Dr. Prashant here on behalf of the organizing committees. Thank you so much, sir.
I would now request our ace retina surgeon of Ludhiana, Dr. Dinesh Garg, to speak on which anti-VEGF to choose in diabetic macular edema.
Thanks, Dr. Rana. And first of all, I must thank everybody, all the luminaries, speakers, Dr. Dogra, Dr. Prashant, and other faculty who has graced the occasion, as also the persons, ophthalmologists who have come from different areas, Moga, Jalandhar, I can see many people around to attend the symposium. So I feel we are, and even Dr. Kalia from Firozpur. So I feel it will make a difference and go a long way in leading to the knowledge of retina for all, for everybody. And thanks to the organization skills of Dr. Nitin, Dr. Rana, and Dr. Neeraj, this is coming out well. Thanks. So before any further ado, I'll just go on to my talk, which is which anti-VEGF to choose in DME. And this is again partly sponsored by the Bayer Group, the educational grant which came from the Bayer group. So a few slides will highlight the molecule as aflibercept. So this is a comparative analysis of anti-VEGFs in the treatment of diabetic macular edema. So the VEGF as well as the placental growth factor, they are elevated in patients with DME and drive the activation of pro-inflammatory cells, vascular leakage and neovascularization in diabetic eye disease. That's what we all know. And VEGF-A and PIGF, they act through the VEGF receptors to play a critical role in the development of diabetic macular edema, increased vascular permeability, inflammation, as well as neovascularization. And aflibercept is a bispecific molecule that targets important VEGF receptors 1 and 2 and has reportedly stronger affinity for VEGF-A and a longer half-life compared to other VEGF agents. We have multiple agents nowadays to choose from, and it can be individual choice, but every molecule has its own advantages and disadvantages compared to the efficacy, the half-life and the affinity and the effect, as well as, of course, in Indian settings, the cost also plays a major role while deciding which anti-VEGF to prescribe. So aflibercept has been designed to bind multiple important VEGF receptor 1 and 2 ligands and has the strongest reported anti-VEGF binding affinity among the approved agents and even the unlicensed bevacizumab. So this is the only globally available antiangiogenic drug that targets VEGF receptor 1 and including the distinct pathways of VEGF receptor A and PIGF. So this is how it binds to the complex, and it prevents the activation of VEGF receptor 1 and 2 activation. The multiple studies, individual studies have reported the binding affinity of different anti-VEGF agents, and aflibercept out of these have the highest binding affinity. And even the half-life, it is 9.1 to 11 days compared to other anti-VEGF agents, which can be 7.2, 9.8 or even 7.5. Bevacizumab is a total or a large molecule which affects the whole of the VEGF, and it has a half-life of 9.8 days. So the binding affinity, again, the binding targets all these agents, aflibercept, ranibizumab, bevacizumab and faricimab. They act on different receptors, and aflibercept acts on VEGF-A, VEGF-B as well as the PIGF. So it has a better effect on the drying as well as the diabetic macular edema as such. So protocol T from the DRCR-NET was a comparative analysis of anti-VEGFs through our randomized clinical trial, which showed that it was a head-to-head trial of anti-VEGFs and it had aflibercept arm, it had a ranibizumab arm as well as the bevacizumab arm. And it showed that the visual gains with aflibercept were superior to those of other molecules at 1 year endpoint, and it was maintained up to 2 years. So it can provide a life-changing vision improvements in routine clinical practice for patients with DME and that are sustained for a longer term. They claim after the loading dose, it works from anything between 8 to 12 weeks. The Fight Retina Blindness Registry, which is kind of giving the real world experience, they also concluded that in DME, aflibercept can achieve clinically meaningful visual gains or maintain vision regardless of baseline vision. So it is a durable and safe anti-VEGF for the management of DME. And it achieves clinically meaningful visual gains in patients with DME that are maintained over 3 years with a reduced number of injections after first year. So in the VISTA and the VIVID trials, in 3 years, the mean number of injections were about 9.4 and 8.3, and then coming on to the third year as 4.5 and 4.6. So aflibercept has a well-established safety profile across all the randomized clinical trials, along with the real-world pharmacovigilance monitoring, which is being done by the company as well as in individual settings. So in conclusion, it is a safe drug. Early intensive treatment of DME in first year, as everybody says and recognizes, leads to meaningful visual gains that can be maintained over a longer term with a reduced treatment burden. Patients presenting with a visual acuity of less than 69 weeks, less than 69 letters, is a commonplace in our practices, especially so in India, and it is the treatment of choice for those patients, which is demonstrated by Protocol T as well as by real-world evidences. It leads to good visual as well as anatomical outcomes in clinical practice, consistent with the reported clinical trials. And Bayer has been supporting real-world studies as well as it has a patient support program, which is now even better. They have recently come out with the latest patient assistance program in which patients can get up to 14 injections at the cost of 5. So in times to come, it may become another factor which will reduce the cost of treatment in these patients. Thanks.
I would now request Dr. Praveen Sen to speak on newer anti-angiogenic agents in retinal diseases.
In the meanwhile, can I request Dr. Ravinder Malli and Dr. Harbhajan Singh to please come and honor Dr. Dinesh Garg.
So a very good afternoon to everyone, and at the outset I must thank Dr. Dinesh and Dr. Nitin for this invite, and it's always a pleasure to be amongst the Ludhiana Ophthalmic Society. So my job has been made easier by the previous two talks by Dr. Prashant and Dr. Dinesh, because they've already introduced you to the common anti-VEGF agents that we are using in our practice. So I'll just take you to what do we look forward to in future. And we all know that we do need, of course, anti-VEGFs have changed our lives and it's changed the way we are treating our patients, definitely, because I still belong to the time when if we could see a subfoveal CNV, we had to sometimes send the patient back that we don't have any treatment for you. But that's not how it is now. We can definitely save the vision of our patients. But this is not an ideal agent, and we do need multiple injections. So we are looking for newer and newer agents which can be more comfortable, improve the compliance of the patients so that patients don't have to come monthly. Because if they are not compliant, the initial benefit which is given by anti-VEGF agents also is all gone. So because of this need, we are coming up with newer molecules all the time, and the couple of molecules which I'll be discussing today with you is, one is Vabysmo or faricimab, and the second is the high-dose Eylea or the Eylea 8 milligram. So first, talking of faricimab, it's one molecule with two targets, and it's the first bispecific humanized monoclonal antibody which has been prepared, and it targets two molecules simultaneously, and which is the VEGF-A as well as the Ang2. Now, what is Ang2 and why are we talking of Ang2 now all the time? We were only talking of anti-VEGF injections. So a lot of reports have come where they have shown that in the vitreous cavity as well as the aqueous humor, you have high concentration of factors other than VEGF as well. And Ang2 is one of those prominent factors. And not only is it present in patients with AMD and DME, it is also seen that patients who have higher severity, so a patient with proliferative diabetic retinopathy will have higher levels of Ang2 as compared with patient who has non-proliferative diabetic retinopathy. So it is probably at some point directly related to the disease and severity of disease. So probably that's why it is important. So if there is Ang2, is there an Ang1? Yes. So these are two ligands of the same endothelial specific tyrosine kinase receptor. So this is a little bit confusing, but I will go slowly on these slides. That this is a Ty2 receptor. It has two ligands. One is the Ang1 and one is the Ang2. So to make it simpler, the Ang1 is actually the hero or the good molecule, and the Ang2 is the villain or the bad molecule. So Ang1 supports normal vascular permeability in healthy eyes. Ang1 is what is responsible for no leakage happening in healthy eyes. But whenever Ang1 is stimulated, it kicks away the vascular increased permeability and leakage and release of cytokines and the whole cascade. So Ang1 is our good molecule. So overexpression of Ang1 results in increased pericyte recruitment, reduced leakage of vessels, and the pathogenesis is that there is no disease. But when there is hypoxia, when there is inflammation, there is release of Ang2, and this causes instability. And not only does it cause instability, Ang2 displaces Ang1, does not allow the Ang1 to act. So not only is there insult, but the protective mechanism is also taken away. It predisposes the vessels to the effect of VEGF, and this is the result. So there is increased permeability and there is disease process. And selectively, if we continue to inhibit VEGF, it can cause a rebound increase in Ang2, and this can result in disease process. So faricimab has two ligands, two attachment points which inhibit Ang2 and VEGF simultaneously, and they have shown in clinical trials, the Tenaya and the Lucerne trial, which has showed that almost 77% of the patients were kept at an interval of at least 12 weeks, and almost 60 to 65% could be kept at an interval of 16 weeks. 16 weeks means almost once in 4 months injections, so the patient can have just 3 or 4 injections in a year, which could be very useful. So again, this reduction in the number of injections was not at the cost of vision gain. Vision gains were maintained, CST was reduced, and intraretinal fluid as well as subretinal fluid was reduced. So DME study was Yosemite and the Rhine, and that also showed that almost 60% patients could be kept on more than 16-week interval, and almost 80% more than 12. And again, efficacy still remains the same. Most importantly, the retinal vasculitis or safety signals were not any more alarming than aflibercept, which has been used very frequently by all of us. So this is in nutshell that it is blocking the Ang2 as well as the VEGF effect, and which is why that newer molecule is here with us. So one of the most important reasons why brolucizumab or the faricimab works is also because of the increased molar concentration of the molecule. So here now Bayer and Regeron have come with something which we call the aflibercept 8 milligram. What we have been using till now is the aflibercept 2 milligram. So what happens if we increase the molar concentration of this highly efficacious molecule which we are using all the time again? So this is the newer one, aflibercept 8 milligram. It has already got FDA approval in last year, August 2023. We are still awaiting approval here in India. And this approval, as I said, the 8 milligram is a novel intravitreal formulation delivering 4 times higher molar dose than aflibercept 2 milligram. And this, they have had clinical trials which have shown efficacy. The photon is for the DME patients and the pulsar is for AMD patients. And here they compared the 2 milligram aflibercept with 8 milligram 12 weekly as well as 8 milligram 16 weekly. And what they have shown is, look at the results. So, you know, almost 80% above 12 weeks, almost 77% above 16 weeks. And look at the gap. So if you look together more than 12 weekly interval, almost 83% of the patients were able to be kept at a dose, maintenance dose of once in 3 months injection. So again, reduce in the number of injection without any compromise on efficacy is what we are looking at, and most importantly, no safety signals. With brolucizumab, we did have some safety signals, and that was probably due to high molar concentration, but here we don't have even with high molar concentration, so this is something which we are looking forward to, but we will know how the experience goes. Photon trial, again for DME patients, similar results, and the patients could be kept, almost 90% patients more than 12 weeks, about 85% patients more than 16 weeks. So these are the results of photon and pulsar study, where they have seen lasting visual gains, rapid and resilient fluid resolution, extended treatment intervals, and comparable safety to 2 milligram aflibercept. So another class is biosimilars. I'll not talk much in detail. Dr. Mohit, who's following me, is going to speak about them. But we are having biosimilars for ranibizumab as well as biosimilars for aflibercept. Leaving you with this one last food for thought. Yes, gene therapy for neovascular AMD is very much around the corner. We all know that monogenic inherited diseases have gene therapy, but why for AMD? How will it work is what we all think. That is because AMD is a multifactorial disease, though many genes have been identified and for AMD, but there are many other complex epigenetic factors. But here, thing to understand is we are not trying to correct the gene. We are trying to give in a gene inside the eye which will modulate the RPE to continuously go on producing anti-VEGF therapy in the eye, so that we do not need to give monthly injections. We can go down to as much as 1 or 2 injections per year. So this is what has been seen in the OPTIC trial. Yes, a clinical trial has already been done for the OPTIC, which is called the OPTIC trial, where they have injected subretinally the gene which is onto the adenovirus vector, and this gene, when given subretinally or intravitreally, as easy as an intravitreal injection, has produced aflibercept in the eye, which has produced an anti-VEGF effect, and the Ixo-vec is the molecule, and this has resulted in the annualized reduction of anti-VEGF injections to almost 0.2 to 1.9. So this is almost 1 injection or 2 injections in a year. So yes, we are spoiled for choices. We are all happy to be in that zone where we are spoiled for choices. And of course, thank you for all the research which has resulted into it, because finally it is the winner is the patient. So we are able to give our better treatment to our patients and look forward to more such treatment modalities. Thank you.
Can I please request Dr. Karamjeet and Dr. Priyanka Arora to honor Dr. Praveen Sen? The remaining speakers can please download their presentations on the laptop so that we don't waste any time. And the next speaker is Dr. Mohit Dogra. He'll be speaking on my experience with biosimilars.
Thank you, sir. And at the outset, I'd like to thank the Jhana Ophthalmic Society, ARC, for the opportunity. The topic that I've been entrusted with today is my experience with biosimilars. And I'd say it's both limited and vast at the same time. It's limited because it's just limited to one drug, which is the biosimilar by Intas, which is Razumab. And it's vast because we've had, I think, extensive experience of using it in PGI. And so it should technically be, my experience with a biosimilar. This is not a sponsored talk, although I'm happy to get some money, make very little money for the working for the government, but yeah, that's a topic for a different day. So this is pretty much the crux of a monthly breakdown of the number of injections that I tend to, give for my patients, so me and my fellows. So about 40 to 45 intravitreal injections per month. This is excluding infectious endophthalmitis. So about 30 would be Razumab, 1 to 2 would be eccentrics. If there are certain parties, who are feeling aggrieved, I can do that and, apologize. Or maybe if they're happy, I can do that and say, whatever. But that is pretty much the breakdown of, the injections and 2 to 4 Ozurdex and 2 to 4 would be others. We have a very busy uveitis practice as well. So methotrexate, clindamycin for your toxoplasma infections and, either combined with anti-CD20 agents or whatever. That would typically be, a breakup of that. So so 4, kind of days in a month. Every Monday of the month is when I tend to give these injections. So this is the breakup. Indications would be similar. You can go on and on with the indications. These are your commoner. I'd say the majority, about 85-90% would be those indications, right? So this is pretty much my experience with biosimilars. With the Razumab, I'm also currently the principal investigator of a trial which we should be winding up, by June if recruitment, is completed. So I have experience apart from the trial. I have, experience within the trial, having recruited about 12, 13 patients, and I think 13 patients of neovascular AMD, in which they get monthly, Razumab for this for a 1-year period, and of course otherwise also. So this is pretty much my breakdown. Majority of the injections we've actually shifted to, biosimilars. And also with aflibercept and I think their patent coming to an end, one of the patents actually came to an end late last year, and aflibercept biosimilars are going to be available soon, I think sooner than we think. The first, I think aflibercept biosimilar, FDA has accepted the application. Phase 3 trials were encouraging, and I think by the middle of this year, Samsung Bioepis is going to have their biosimilar out. Amgen already, the company that I talked about, should have their biosimilar out. So, those things will also eat into, I think, the Eylea market. And I'm just going to show 5 cases. I've actually presented this one time before at I think one of the LOS meetings, and just going to show 5 different non-DME, non-neovascular AMD cases in which to just kind of cover the gamut where maybe Razumab worked since this was on biosimilars, right? So 50-year-old female had diminution of vision in both eyes for a year, with further deterioration of vision in the left eye for a month and a half. Has received the intravitreal Lucentis 25 days ago elsewhere. This is, sometime back, 2018, and systemic history was fine. That's what the patient had. Typical, the photo showing up pretty well. Typical, you want to call it perifoveal telangiectasia, you want to call it a MacTel. It's your pick. The right eye does not have a membrane. The left eye has a neovascular complex, as you can see, and SHREM, which is subretinal hyperreflective material, just temporal to the fovea. So there's a membrane in the left eye, needs treatment. The right eye showed some kind of a dilated capillary network. The left eye showed that membrane in the avascular retina also, with increased flow on the cross-sectional OCTA. Since there was no SRF, there was no hemorrhage, I asked the patient to come back, had already received the injection elsewhere, presented 20 days later with blurring of vision. The right eye also now has, has like a very fine frond, as you can see in that third slab from up top. The frond in the left eye, of course, has grown much bigger and the patient is symptomatic, and there is SHREM, and there is also subretinal fluid. So this is again the right eye, which has gone up 20 days apart. The left eye, the membrane which was crenated is now not as crenated. It's almost has branching margins. And again, was treated with Razumab this time purely for financial reasons. And this was one of the earlier patients, 2018, when we were actually giving a lot of those, and did very well. The patient had actually come to PGI specifically for financial concerns and could not afford the parent molecule. So, did well, continues to do well, and in fact. And so this is just MacTel, which was treated with multiple Razumab injections, did well. This patient, again, type 2 diabetic, type 2 diabetic mellitus on oral hypoglycemics and insulin, had a amputation of 2 toes of the left foot 6 months back. I underwent an uncomplicated phaco-IOL 2 months back, and PRP elsewhere. No history of other kind of issues, but this is what the patient came back, actually had. Acuity 6/60, intraocular pressure 26. Although the cataract is significant, but you could still make out what's going on in the fundus. There's a pre-macular bleed, and you can see there is a detaching hyaloid because of the pre-macular bleed, and that's what the OCT showed. This is the other eye which had undergone the so-called uneventful phacoemulsification. You can see the NVI, all around the pupillary margin. The IOLs in the bag. There was also fluoride NVA. This patient actually, that's the fundus. There's a fibrovascular proliferation and a bleed. That's the traction shown there. The right eye, that's what that's the level of ischemia that the patient had. There was almost an abrupt cutoff. There was no perfusion going beyond the macula temporally. Octa also kind of. So basically, what I want to show, the case is separate since the topic is of Razumab. But even in such a scenario where you want to try and combine this with very aggressive pan-retinal photocoagulation, you can actually give the drug, which is the drug that I gave at that point in time. The patient actually went ahead and could later undergo phaco and IOL, and did well. That was, by the time we were done with all of this treatment, the cataract had actually gone up to that, and post phaco IOL, that's what the patient did, and actually did well. Another kind of interesting patient. This patient actually had a macular hole, underwent a vitrectomy, ILM peeling with a flap, and actually went on to develop post-macular hole closure choroidal neovascular membrane, which is a rare but a dreaded complication of this, especially with all of these flaps, because there can be micro RPE trauma if you're trying to stuff the hole with those flaps. And unfortunately, that's what this patient got. And you can see that's the big fluid, all the holes closed. That's the big fluid foveal neovascular membrane. Again, was treated with multiple Razumab injections, and you can see the crenation, all the acuity is only modestly improved, but you can see the crenation and almost disappearance of all of those medusa heads. So can be given for these post-surgical vitrectomized patients also. And just going to finish with this, maybe skip the fifth case for want of time. This is uveitis, and this is one of the first patients that we saw that we treated in fact with intravitreal anti-VEGF. This was a tubercular choroidal granuloma involving the macula with subretinal fluid, and you can see that the choroidal architecture is gone, and there is presence of fluid on the OCT. The angiogram confirms it. The patient had systemic evidence of tuberculosis with hilar lymph nodes, and although the HIV was negative, the intravitreal Razumab was given, and at the same time the Vitrostap was sent for a TB PCR, which turned out to be positive for both IS6110 and the RPOB gene. So we test for 3 different genes for TB PCR for their TB bug. So 2 out of those 3 were positive for this patient, so which made it a definitive proven case of intraocular TB with a choroidal granuloma. And this patient was just treated with systemic ATT, no steroids, and an intravitreal 1 shot of Razumab. 4 days later, 10 days later, 21 days later, you can see that there is first resorption of the fluid, then the granuloma goes away, and you can see the OCT, which shows the structural correlate of what we just saw on the fundus photo. The choroidal thickness tends to normalize, the fluid's gone, and at 9 months follow-up, it almost looks like this patient had nothing. And mind you, this is with just 1 injection and 6 months of ATT, not 9 months, because it was 6 months, because the ATT was given by the pulmonologist from their viewpoint. Had we started with no pulmonary evidence, it would have been 9 months. That's that. This was, again, this was during COVID times, this post-COVID related, this young lady got a COVID vaccine, and actually got a COVID vaccine-related indeterminate CRVO with CME, was treated with 1 injection of Razumab, and you can see, all of those things got away. The patient did well. The acuity got back a lot better. So even in post, vaccine, immune/infectious, retinal vein occlusions, this can be given with some degree of safety, and the efficacy not being affected. And I know that Simar and Dr. Diksha give this a lot also in pediatric cases in their, I don't do ROP, but also in premature babies who need it as either a temporizing measure or along with laser. So it's also, I think, fairly safe to be given for premature babies. Thank you.
Thank you, Dr. Mohit. That was a very enriching talk. Anybody has any questions? Please go ahead. Next talk is by Dr. B.S. Rana, and he'll be speaking on anti-VEGF injections by anterior segment surgeon, the pros. And may I request Dr. Nitin Batra to please honor Dr. Mohit Dogra.
Good afternoon. Dr. Amod Gupta had once commented that you teach these private practitioners a new thing and then they will continue using it even without indication. 15 years after private practice, I feel he was right, because many a times anti-VEGF injections are given, and I have also seen in my practice that they are given without some indications. But as a perspective of an anterior segment surgeon, I would like to discuss some pros and cons with you today. Anterior segment surgeons are generally first point of contact of the patient. There are approximately 3 million people aged 40 years or older having vision-threatening diabetic retinopathy in India. Almost the same number of the patients will be having ARMDs and BRVOs, CRVOs. And as it is, retina surgeons are not freely available. There are almost 1,500 members in VRSI. So large number of patients requiring injections cannot be catered just by retina surgeons. So anterior segment surgeons are like knights in shining armor. So they ensure the timely treatment is given to the patient. And moreover, all the retina surgeons are mainly settled in bigger cities. So treatment is now possible even in small towns if the anterior segment surgeon is giving the injections. Moreover, the patients are more comfortable with their cataract surgeon, who is like their family physician. They come for each and every problem. Their first point of contact is a cataract surgeon. They will come to him for any problem they have in the eye. But then there are some things which we can learn as anterior segment surgeons. These are not very difficult things, like vitreous hemorrhage. Anti-VEGF is not a solution for all cases of vitreous hemorrhage. As soon as we see vitreous hemorrhage, we rush in to give anti-VEGF injection. But there are some conditions in which actually anti-VEGF is contraindicated. I will call it 3 T's: tumors, trauma, and tears. In tears or in PVD also, you can see some vitreous hemorrhage, and retinal detachment also, you can see a vitreous hemorrhage. In dense vitreous hemorrhage like this, one is tempted to give multiple injections. So anti-VEGF results in increase of fibrous component of fibrovascular proliferation. As a result, traction increases and the surgery becomes difficult. So in severe persistent vitreous hemorrhage and dense persistent premacular hemorrhage, progressive proliferation despite laser therapy, and in RD, vitrectomy is indicated. So the timely referral needs to be done in these type of patients. Endophthalmitis is also common with anterior segment surgeons giving the injections, as volume of patients needing injection with each cataract surgeon is limited. So we share the vials for a longer period, and so thus more chances of infection in these type of patients. Now litigations are very common in these days. need for training in medical retina needs to be explained. Once any consumer forum case, you need to show that you have been trained in medical retina, so before giving some injections. Cause of disease must be ascertained before injecting the patient. Documentation of procedure has to be done. Timely referral has to be started. Timely treatment has to be started, and timely referral has to be done. Because tomorrow the patient comes and asks you that why wasn't I referred if I had RD? So you should have an answer. Drug interactions, actually, I also did not know before making this slide, because very interesting drug interaction with the live vaccines, that it may result in reduced immune response. Or while you are giving live vaccine, you are co-administering your live vaccine with the anti-VEGF injection, it may result in the reduced immune response of the live vaccine. There are some adverse effects like thromboembolism. We all know about thromboembolism, but an interesting side effect which is more common with intravenous but has been seen with the intravitreal also is alopecia. One of my patients came and told me that I am facing hair fall. Every time you give me an injection, I have hair fall. I did not know that it was due to, due to this anti-VEGF injection, but now I'm well aware, and if your patient asks you about any adverse effect, you should know it, because you are giving the injection to the patient, and if you don't know the side effects, it is not good for them. So in mild vitreous hemorrhages also, I have seen lots of people giving anti-VEGF injection. So there is spontaneous resolution in these cases. So one should wait for at least 4 weeks before giving an injection. There's a vitreous hemorrhage, and then you come to know that it was due to retinal detachment, and you keep on giving anti-VEGF injections, so it will cause delay in surgery, which will cause PVR changes. So VR surgery becomes difficult, or sometimes even it becomes inoperable, and recurrence of RD is also there due to PVR, and again it is a source of litigation. B scan is very important before giving an anti-VEGF injection to rule out all other causes. So mostly our clinics, anterior segment surgeon clinics, do not have a dedicated B scan. What we can do is you can get it done from a radiologist friend. So the transvaginal probe they use, they have almost the same frequency as a B scan, and you get a fairly good idea what is happening inside the eye if you use a B scan as a modality before giving an injection. In Eales disease, intraocular bevacizumab has been found to be useful in treatment of neovascular Eales disease, or as a possible adjunctive treatment to VR surgery for management of the same with tractional retinal detachment. However, this treatment has a legacy of serious complications like secondary rhegmatogenous retinal detachment within a week of receiving intravitreal bevacizumab. So the patient should be followed properly after giving an injection, because secondary rhegmatogenous retinal detachment sometimes missed. Combination therapy of laser treatment and intraocular bevacizumab was effective in improving and stabilizing the disease. So I have seen some surgeons giving anti-VEGF in ROP, but it is very tricky. Bilateral injections have to be given in same sittings. Neurological side effects have been seen in long term, and role of anti-VEGF is just limited to zone 1 disease and zone 2 posterior disease. Once the injection is given, so the post-injection follow-up becomes very difficult. Baby becomes healthier, bigger, and heavier with time. So examination under anesthesia is required. And moreover, the post-injection recurrence is different from normal ROP. So if one is not trained in seeing the patient of ROP, so then this type of the reoccurrence would be very difficult for a surgeon to identify. So this is a B scan, the same machine which I was talking. So you can see this is a vitreous hemorrhage with membranes you can see. So you get a fairly good idea if you have this machine, or you can get your, the patient done from one of your radiologist friends. So Kenalog became the first intravitreal drug with widespread application. It was used for the treatment of macular edema associated with various etiologies. So there are many other like Eylea, and then there are steroid implants, and then there are antibiotics. This is very interesting to note that there is a strange aversion to all other group of drugs given intravitreally, because anterior segment surgeons do not like to give antibiotic with the same confidence they are giving anti-VEGF. Implants are a big no-no. Will give multiple injections in refractory edema, because if once they see that the patient is not improving, they do not shift on to implant. Even the newer anti-VEGFs are not that well embraced by anterior segment surgeons. And triamcinolone is a very cheap alternative, but I have never seen any anterior segment surgeon giving triamcinolone. Fluorescein angiography machine is strangely absent in many of the clinics who give anti-VEGF, but it is very important to identify capillary non-perfusion and subtle areas of neovascularization which are causing recurrent vitreous hemorrhage. So once you are giving anti-VEGF, so you do not know what is the pathology behind it, and you continuously keep on giving it. And laser photocoagulation is another thing which should be done. If you are doing anti-VEGFs, lasers should be with you in your clinic. Because the good involution shows, there's a picture showing good involution versus poor involution. The persistent neovascularization and hemorrhage will be there if there is a poor involution. And regression of neovascularization, leaving ghost vessels or fibrous tissue, decrease in venous changes, absorption of hemorrhages, and disc pallor would be seen if the involution is good. So this is the last slide, but I think this is most important thing, because systemic management is commonly missed by anterior segment surgeon. So if you are giving anti-VEGFs, you need to counsel the patient for good glycemic control, blood pressure control, and giving statins and fibrates along with. And renal function should be good, and lifestyle modification also should be taught. Thank you very much for your time and attention.
I will request Dr. Ashwini Kalia and Dr. Rajesh Garg to please come and felicitate Dr. Rana.
Thank you for highlighting those very important points, actually.
The next speaker is Dr. Mayank Datta. He will be speaking about cons of anti-VEGF injections by anterior segment surgeon.
I would like to thank the Ludhiana Ophthalmological Society and the organizing committee for inviting me to express my views on this topic. I would be debating upon the pitfalls of anterior segment surgeon injecting intravitreal drugs. Who should be giving the intravitreal drugs is a matter of some opinion and some controversy as well. This debate actually has come to fore in the modern era of anti-VEGF therapy. Actually, all types of intravitreal injections can be and are being given by the anterior segment surgeons and general ophthalmologists. While giving an intravitreal injection is technically within the skill set of any ophthalmic surgeon, since all are well versed with the ocular anatomy, there is no debate in this, and this has been made clear by my previous speaker. The real question, however, we should be asking ourselves is that who should be advising intravitreal injections and who should be following them up? Injecting, we can agree upon, is the easiest part of the procedure. The hardest part is the diagnosis and deciding whether or not the patient will benefit from any intervention and the ability to manage the complications if this so arise. And in this regard, there stands no debate at all. Only the posterior segment surgeons and medical retina specialists should be advising intravitreal pharmacotherapy and monitoring the patients on follow-up after the injection. Now, why is it so? Because a formal and a thorough training in retina helps in understanding the nuances of vitreous and retina, and thereby bestows upon the individual the skills necessary to act in the best interest of the patient. Now, let us look at a few scenarios which we are regularly experiencing in day-to-day practice and which are by no means uncommon. While treating vascular pathologies, many times we come across so many different possibilities, like macular edemas which do not affect vision at all. Sometimes macular edemas, they respond, but they respond very suboptimally, or they may not respond at all. Whether to go in for a monotherapy with an anti-VEGF agent or to combine with the intravitreal steroids, how to tackle concurrent macular ischemia, when to order an angiogram, when and how to incorporate a PRP. Now, while treating neovascular AMDs, which again constitutes a major chunk of pathologies which demand anti-VEGF agents, we commonly come across the dilemmas like indolent occult CNVM with good vision, whether the PED is associated with CNVM or not, and whether it requires treatment, how to respond to a PED, determine the type of CNVM, whether it is a RAP lesion or a IPCV, which anti-VEGF would be better suited for a given patient, whether or not the fibrosis is set in, and when to stop treatment, how to respond to a recurrent CNVM, so on and so forth. Now let me illustrate with a few examples. Very commonly we see the patient of vitreous hemorrhage in our OPD like this one. This patient was seen by an anterior segment surgeon, was a diabetic, presented with 6/18 vision and sudden onset of floaters. They had some blot hemorrhages in the retina with some media haze because of vitreous hemorrhage. There was a small patch of myelinated nerve fibers nasally which was mistakenly labeled as a soft exudate, and he was diagnosed to have PDR with vitreous hemorrhage. He was injected Avastin and followed up a week later. There was no significant relief to the patient, and he came to us for a second opinion. Now this was a picture we took. There was some media haze because of vitreous hemorrhage. And on examination of the periphery, we saw a horseshoe tear which was promptly lasered. Now in this particular instance, not only the Avastin was injected unnecessarily, but also the HST was missed, and the patient was lucky not to land up with retinal detachment. This again does not mean that these types of errors cannot happen with retinal surgeons. They can, of course they can, but again, as previously mentioned, the proper training and mindset minimizes the chance of such an error happening and keeps us aware of such a possibility. Now, this is another patient who had aggressive PDR with plenty of FVPs around the arcade. He presented with vitreous hemorrhage. We took a color fundus picture and advised to proceed straight away with PRP. But the patient went to another anterior segment surgeon for a second opinion who preferred to give anti-VEGF agents. 3 injections at 4 to 6 weekly interval were given. No laser was done, and patient again came to us after 6 months with a macular TRD. You see the bad macular TRD landing with the patient. Again, macular TRD could have occurred with the PRP sitting alone. But again, in a setting of proper VR setup, the same could have been diagnosed and treated promptly. Now, many times the anterior segment surgeons, in their zeal to give anti-VEGF therapy, because again of the ease of giving, and it is also more financially rewarding, they forget that there are other modalities available to treat macular edema as well. Like these 2 patients, the right eye of these 2 patients, who had received multiple anti-VEGF injections, there are hardly any relief to them. We just did gentle focal laser to the center of cercinates, and you can see the results in the lower panel for yourself a year or so later. Now, again, injecting without an access to angiogram, which is most often the case with anterior segment surgeons, denies us the ability to delineate the non-perfused areas, macular ischemia, and the NVEs, which may be subtle sometimes, but again are a source of trouble. Now, again, a thorough training which we receive prevents us from injecting where it is not required, like for example vitreomacular traction, perifoveal telangiectasia, and so many other pathologies like retinoschisis, which just happen to show a cyst on OCT, but do not anyway require anti-VEGF therapy. Even if it is argued that anterior segment surgeons, they possess the necessary skill and expertise to diagnose and treat common vitreoretinal pathologies, it is very surprising indeed that we come across most of the intravitreal injections being given as anti-VEGF agents. We hardly come across IVTA being given in any patient, even if it makes a compelling case in few of the patients. We must remember that IVT is also a distant cousin of anti-VEGF agents, although it is a poor one. So very few surgeons seem to talk about it. Again, because of the lack of good training, and secondly, it is not very financially rewarding. Now, again, another important paradox we sometimes encounter is that while anterior segment surgeons are more than keen on injecting anti-VEGF agents repeatedly for diabetic macular edema, the reluctance in injecting intravitreal antibiotics in an unfortunate complication of post-cataract surgery endophthalmitis is many a time very obvious. While they will very happily inject Avastin and DME again and again, in case of DME, we often see them injecting subconjunctival gentamicin and dexamethasone repeatedly, or depomedrol in the deep subtenon space when they when all they have to do is to just inject intravitreal vancomycin with ceftazidime. The point here is, if you cannot manage this pathology till the end, you should not be managing the diabetic macular edema as well. Now again, whichever anti-VEGF agents we may give, they incur a significant financial burden on the patient, and by the time patient reaches a posterior segment surgeon and needs actual surgical VR intervention, he or she is financially drained and cannot arrange enough funds for a vitreoretinal surgery. Now, coming to this conclusion, although this debate is never ending, the honest opinion in this debate lies in the answers to the questions you all must be asking yourselves. If your own family member needs an intravitreal injection, whom would you like to diagnose, inject, and follow up? I think no more arguments are needed from here on. Again, hence the intravitreal pharmacotherapy should be advised by a posterior segment surgeon, can be again given by any ophthalmic subspecialty, followed up and treated by a posterior segment surgeon or a medical retina specialist, and good access to B-scan, angiogram, laser, and surgical setting is mandatory. Now, we all know that, however, the scenario is unlikely to change. The debate shall continue. Anterior segment surgeons and general ophthalmologists were giving, are giving, and shall continue to give intravitreal anti-VEGF injections. They should keep in mind the following points. Be reasonably sure of diagnosis before injecting. Follow cardinal rules for a sterile technique. It is better to refer one-eyed patients, especially the ones with unusual presentation. Refer any patient who is not doing well. Be sure you are comfortable identifying, managing, referring the potential complications of injection. At the very least, have somebody readily available for referral. Thank you for a patient hearing.
Thank you, Dr. Mayank Datta. I will request Dr. Sudhir Salhotra and Dr. Saveen Gupta to please come forward and felicitate Dr. Mayank Datta.
Concluding remarks.
I think we had great session, especially I think dedicated to, I would say, anti-VEGF injections. In today's time, perhaps maybe we are in a position to beat our cataract surgeons, that we'll be having more injections than the cataracts. And with so many of them coming in, and now of course biosimilars, I think we are into an era where perhaps we'll have more and more injections with benefit to the patient, what has been highlighted with the durability as well as having more efficacy and safety also, of course, which is a factor. So great session. Thank you. I'm sure everybody got a benefit.
Thanks. Thank you, sir. And I think with these words, we'll conclude this session and we'll go on to the next session.
Okay, we'll go at the next session. I know it's lunch time, but kindly be here for another 45 minutes or so. So we'll have lunch immediately after the next session. So there is a small change in the sequence. The first speaker for the next session is Dr. Abhinav Dhami, and he'll be speaking about recent advances in macular surgery.
Hi, good afternoon everyone. I think it's been a great session till late. Sorry for jumping the leap. And I'll be talking about recent advances in macular hole surgery. It's one of the most perplexing surgeries, even as a resident, even till now, because the outcomes don't invariably match the surgical skill. And we know the macular hole is a vitreoretinal interface disease characterized by partial or full thickness neurosensory retinal defect in the center of the macula. Due to the central foveal involvement, you do have metamorphopsia, you have visual deprivation. As a common presenting symptoms, they may be reversible after successful lateral closure, but may not be completely gone. The etiology is there's a whole list of factors, mostly idiopathic, related to the vitreomacular traction. It can happen after laser treatment, after intraocular surgical interventions, as Dr. Mohit has shown, even after epiretinal membranes, post any of these PCVs and even hypertensive retinopathy, diabetic retinopathy, and even the common vitelliform diseases, and after the RAMS. So basic risk factors is that the incidence of macular holes is as high as 7.8% per 1 lakh population. The bilateral involvement varies from about 2 to 28%. Females are more commonly involved. There was a recent paper in IGO this way in which they actually showed that the fovea thinning or the stretching of the fovea is more in females as compared to men, and happens more in the 6 to 7 decade. And the fellow eye involvement is about 10% 5 years. So these patients have to be routinely followed up. The pathogenesis is pretty simple. You have the posterior hyaloid, which causes the traction on the umbo of the foveola. There's a dehiscence of the central part. The upward and the tangential traction causes the fluid from the vitreous into the central space. Causes the whole enlargement, and the fluid reaches the inner retina also. The classification as composed by gas has been what we have been following till now, and we have a stage 1 in which you have detachment of the fovea. Anybody who sees on the does 90D scan, they can see this yellow ring that comes up, and this is pretty specific that there's a macular pathology that's happening. It can be a 1A, 1B depending on what the fovea or the foveola is involved. But these type 1s can still close even after and there are 50% chance that they may not need a surgery. When you go to type 2, it is less than 400 micron size, a full thickness, sensory defect is there. Sometimes you may even find an attached posterior cortical vitreous, and almost 100% of these cases will go on to a stage 3. Stage 3 would be a size of the central neosensory defect of more than 400 microns, and stage 4 is basically when there's a puberty present, you can see the complete separation. The examination by anybody can be done. You can do a Watt-Scale test. You will see that the patient will specifically say, I can't see the central part of your beam, which is pretty specific and can even be used in other diseases also. The most prognostic factors that we assess for surgical success for me has always been a basal hole diameter, but we have been using the hole form factor and the macular hole index or the tractional hole index. But a basic, if the macular hole the basal diameter is more, definitely then can be a very risk factor for whether the hole will close or not, and whether your success for the functional and the anatomical outcomes will match or not. Treatment has definitely evolved over time, and we have better cutters now, we have better forceps, we have better dyes to stain and to fill the macular hole. So basic goal is you do a complete vitrectomy, do an ILM peeling without an ILM flap. You can use the getting of the gas tamponades. You can use SF6 or a C3F8. The closure is definitely the same. But we've been characterized, what we've been doing is if it's less than 500 microns, we use SF6. If it's more than 500 microns, I've been using C3F8. The only problem is C3F8 stays inside the eye for a very long time. The patient gets very fussy that he's not able to see because of the gas. Chemical vitrectomy has definitely been tried. They have tried intravitreal ocriplasmin, but the only problem is it can only give you a 58.3% closure rate in less than 250 micron diameters of the macular hole. So not much. So you have to go back to the surgical part only. And in choosing dyes, I think there has been a preferential choice. Some people like indocyanine. I preferentially do like brilliant blue because I don't. The safety concerns with visual acuity defects and visual field defects are higher with indocyanine green versus the brilliant blue. These are the panorama of ILM closure techniques that are available and have been studied in literature, but of all the things that works for us is the inverted flap technique. That makes you happy the very next day because you can see the closed hole, but there are the foveal sparing and the ILM abrasion, the cover and fill. There's been a use of viscoelastic to push to cover the flap onto the macula. And usually nowadays a lot of people are using autologous blood, and also the fibrin glue has been brought into picture. I have no experience with fibrin glue till now, but so how to achieve the inverted flap? It's pretty simple. You either use a small MVR blade. You have a huge list of vitreoretinal forceps. You have the diamond duster scraper, that's a Keynote scraper. You have the finesse flex loop that's available by the Alcon group, and we have also made a new forceps. It's called Dhami's ILM peeling forceps. I'll be showing the video. So coming on to the pinch and peel technique, it's a simple technique. So basically what you're doing is you're holding the forceps, you pull the ILM, pinch it up slightly so that you create an indent, and as you do it, the ILM gets pulled upwards, creating a small traction separation of the ILM. And as you do pinch, pull and leave, and then you just pull the ILM and it separates out. The finesse flex loop I initially learned ILM peeling with Dr. Dhanashri while using this finesse-like loop, and I used it for a long time in my practice. It's pretty simple. It has an inositol loop which has some reagent that you can gently just peel the ILM, scrape it, lift the edge of flap, and then you can use the forceps, any of the ILM peeling forceps, to peel the ILM completely, and you can use any of the techniques. You can fill or cover the the macular hole using an inverted flap technique, and will give you a good outcome. This one point that was taught to me by Dr. PK ma'am was that you always have to leave a nasal hinge, and I think that's been stuck in my head, because he says otherwise the flap will become free and you will end up losing the flap. So I think that's one point I have never forgotten till that. And so next is our forceps. This has been designed by me and it's been available with Epsilon. This basically is a C-shaped forceps. So basically the edges of and the tip of the forceps is diamond dusted. So you can actually use the edge or the tip to scrape the ILM, and the best advantage is that you don't need to come out of the eye again and again. You have one instrument that is peeling the ILM, and the similar instrument is also enables you to pull the ILM and close the macular hole. That saves you time and actually saves you cost also, because if you use any finesse, the cost of the instruments goes low, because if you're buying an instrument, like you're buying a finesse flex tube, or you're buying any intraocular forceps, is going to cost around 25,000, and this is around 14,000. And till date, with singular forceps, we've done about 50 cases, and we have not had to change it. So definitely an advantage with this forceps, and you can see the ease is very simple. It takes a couple of cases to understand how much to pull the retina, how much to pull the ILM, and you can just pull the ILM onto the macular hole and fill in the gap. One other advantage is that since it's C-shaped, so if you used the Alcon Grisha Shark chin, it actually has striations, so there's a seepage of water. So your flap tends to get pulled into the forceps. It doesn't happen with this. So conclusion, yes, early management is critical, and more than 9 months of duration does cause reduced closure rate of MH. The minimum basal hole diameter for predicting a good anatomical success rate is 747 microns. Aldrich et al. Found that the whole form factor of less than 0.9 shows a markedly higher closure rate rather than a whole form factor of 0.5. Vitrectomy with the ILM peeling is currently the primary method. The closure rate is as high as 90%. Anatomical and visual potential may not correlate to your macular hole closure. If the patient has no risk factors, that duration is not greater than 1 year, or has a high myopia, or has a whole diameter greater than 400 microns, and the maintenance of prone position can be stopped after the hole closure using the OCT. So basically after day 1, you don't need to give a closure, but we still do give a prone position for about 5 days. Thank you.
Thank you, Dr. Abhinav. I will request Dr. Ajay Kapoor and Dr. Balwinder to please come forward and felicitate Dr. Abhinav. Dr. Balwinder was here. Yes. Next speaker is Dr. Karanjit Singh, and he'll be speaking on recent advances in retinal diagnosis.
Good afternoon. First of all, I am thankful to Ludhiana Ophthalmological Society to giving me this opportunity to speak on this platform. So my talk is very simple. Basically, what recent modalities we are using for diagnosis of the retinal diseases. As we all know that the diagnosis of number of chronic retinal diseases, including ARMD and diabetic retinopathy, has been improved by the technological advances in the imaging techniques. So we have these days fundus autofluorescence, OCT, the newly introduced OCTs, and OCT angiography. These are basically non-invasive techniques and able to identify clinically relevant lesions in the retinal vascular disorders while avoiding the potential side effects of traditional dye-based angiographies. So new modalities which are in our hand these days are the ultra-wide field imaging, then fundus autofluorescence, swept source optical coherence tomography, NFAS optical coherence tomography, and OCT angiography. So I am speaking on basically OCT angiography. OCT is non-invasive imaging tool that detects the flow signals to provide images at different retinal and choroidal vascular levels. So simultaneously, without the injection of dye, OCTA utilizes the intrinsic motion contrast to the map vascular plexus. So the advantage of this technique is that it allows automatic quantitative measurement of the vascular density at different retinal levels, which we are missing with traditional OCTs, like superficial capillary plexus, then intermediate capillary plexus, and deep capillary plexus, which has a significant value in few of the chronic retinal diseases. And it has with the high repeatability and reproducibility. So recently, with the use of wide field SS OCTA technology, which is recently introduced, so we enable to enhance, even acquire the various OCTA images up to 12 into 12 mm as compared to conventional OCTA images. So wide field OCTA can also be used in combination with the other investigation modalities to see the vasculature of the diabetic in diabetic patients as well as in other chronic diseases. So these are the few clinical applications of OCTA. PCV is in PC to diagnose the PCV and to subclassify the PCV. OCTA is very much helpful. So PCV is basically a subtype of neovascular AMD, so which is characterized by type 1 neovascularization associated with aneurysmal dilatations, which are basically of polypoid nature, and branching vascular network. So conventional IC angiography, which was previously thought to be gold standard for diagnosis of the PCV. Now we have this OCTA, by which we can classify the subtypes of PCV also. IC angiography, we all know that it is an invasive investigation and it requires intravenous dye injections. There are so many side effects of these dyes. So non-ICG based features such as fundus photoappearance and OCT features with high sensitivity and specificity is these days used to differentiate PCV from other type of neovascular AMDs. So in 2021, the Asia Pacific Ocular Imaging Society proposed non-ICG based classification of PCB. So this classification is basically used these days to classify the PCV. So basically there are 9 features which are which we consider on OCTA. 6 based on the cross-sectional OCT and 2 on the fundus photography and 1 on NFAS OCT. So we combine all these features, and after that we classify the PCV into various subcategories. So these are the features on SD-OCT, NFAS OCT, and fundus photography. These are the 9 features so which are used to subclassify the PCV on OCTA. So these are the few examples. These are the photographs I borrow from one of my friend as we recently acquired OCT. The fundus photo, the first photo shows the macular hemorrhage with orange nodule. Then the SD-OCT show typical feature of PCV, that is sharp PED with adjoining double layer sign, which is characteristic on OCT. And OCT angio showed compact tangled vessels, which are basically red in color, tangled vessels that corresponds to polypoid lesions on ICG angiography in the upper picture. So this OCTA is helpful to subclassify the PCV in various substages. So branching neovascular network, it also reveals on OCT angiography is basically that of PCV. So this is another example of a fundus photo of 72-year-old woman which shows exudative maculopathy. So SDOCT shows intraretinal fluid in the inner layers of the retina, then irregular retinal pigment epithelium and hyperreflective dots. The ICG shows multiple tiny hotspots on the ICG that were non-pulsatable and not surrounded by the dark halos. But the octa did not show any signal on this. So the octa is blank on this. So it indicates that the vascular network is basically in the outer retina. The FA show mild late leakage and multiple staining, which were also present in the periphery. So in this way, the various technologies are helpful in diagnosing various chronic diseases. So this is basically a picture of 55-year-old man with complex central serous chorioretinopathy. So with wide field imaging, so you can see that there is on ultra wide field imaging, there is a diffuse retinal pigment epithelium changes. Then multifocal leakages were found on fluorescein angiography in the second picture and on ICG. The OCT angio shows that there is basically the signal strength is more in the central area as compared to the adjoining area. So this shows that there is some activity in this field which is the cause of central serous chorioretinopathy, which is of chronic nature. So this is about the OCT angio. Then the ultra wide field imaging, which these days is helpful in imaging the central as well as the peripheral retina. So these machines are mydriatic as well as non-mydriatic machines are available these days. So it makes the use of SLO technology that captures around 200 degrees of retina with or without mydriasis. So it provides opportunity to visualize the peripheral as well as central retina simultaneously. And ultra wide field angiography is used to assess the peripheral retinal vasculature and ischemic areas in the peripheral retina, as in diabetic retinopathy, retinal vein occlusion, and it is very much helpful in retinal vasculitis. So we can clearly see the changes in the retinal vasculature in retinal vasculitis. So it is also helpful in pediatric patients who are uncooperative during image acquisition, like in ROP and in Coats disease. So ultra wide field angiography is also can be done so to see the peripheral exudative hemorrhagic chorioretinopathies, which is basically a disease which is anterior to the equator. So it has been found that polypoid lesions were found to up to 70% in the peripheral exudative hemorrhagic chorioretinopathy, which is thought to be a variant of PCV. But disadvantages are image distortion can occur up to 5 to 10% of images because of two-dimensional representation of a three-dimensional surface. But with the experience, we can acquire the montage images of the peripheral retina also, so we can clearly see the images in the peripheral retina also. And also the eyelash artifact may also appear during the image acquisition. So these days we are also using this wide field. We have Claris camera with us. We are using this for document maintenance in cases of ROP babies. So with this floating baby technique, we are seeing zone 2 also in ROP babies, and also we are making montage in ROP babies. Fundus autofluorescence, we all know that it can identify the RPE atrophy and RPE RIP in cases of AMD, and it also provides a prognostic value. So F is very much useful along with the either fluorescein angiography or along with the ultra wide fundus imaging techniques. So FAF is able to assess the macular displacement following retinal detachment repair surgery. So it is very much useful after RD surgery to see whether there is any displacement of the macula after RD surgery. And also there is a quantitative comparison of autofluorescence between the different raw FAF images with the other images also. Now the third modality is the swept source OCT. Swept source OCT is basically a tunable laser for frequency based. This has a photo detectors that can be used along with the conventional OCTs, so that makes them the tunable images. So it has a longer wavelength as compared to the other SD OCTs or other OCTs. So as a result, it provides high resolution images of the vitreous, retina and choroid simultaneously without any sensitivity cutoff. But limitation is there is slight decrease in lateral resolution as compared to SD OCT or other type of OCTs. SD OCT may visualize the choroidal vasculature and type 1 choroidal neovascularization better than the spectral conventional OCTs. Then another is the N-phase optical coherence tomography. It produces layer-to-layer coronal images of the retina as opposed to conventional cross-sectional OCT images. So these images are basically, these images are digitally reconstructed using high-density volumetric OCT scans. So the application of this includes classification of the lamellar holes, macular pseudo holes, and measurements of geographic atrophy in cases of chronic AMD patients, and assessment of the perivenular ischemia in cases of retinal vascular disorders, and to diagnose the PCV. So to conclude my talk, technological advancements allow the high resolution, depth resolved and non-invasive OCT images of the chorioretinal tissue as well as microangiography. The application of advanced retinal imaging techniques has had a major impact on the clinical management and paradigm changes in diagnosis, subtype classification and prognosis of retinal diseases. But as our teachers taught us, the good indirect ophthalmoscopy is a gold standard even after having so many newer modalities of diagnosis. So thank you very much for your patience hearing.
Thank you, Dr. Karamjeet. Dr. Karamjeet also happens to be the Secretary of Punjab Ophthalmological Society. And I will request Dr. Parveen Sen and Dr. Shafi to kindly felicitate Dr. Karamjeet.
So now we'll call upon young, dynamic Dr. Simar. Thank you so much for accepting our invitation and all of you coming early in the morning from Chandigarh. So Dr. Simar is speaking on recent advances in hereditary retinal disorders.
Thank you so much, sir. At the outset, I'd like to thank the Ludhiana Ophthalmological Society, Dr. Batra, Dr. Dinesh Garg, and the ARC AIOS. So I'll be talking just briefly about the recent advances in inherited retinal diseases. So it's kind of a dry topic, but there are many new advances that are taking place in this field. So it's time to get up to date with this. So inherited retinal diseases are a group of phenotypically diverse disorders, and they have varied genetic mutations. So there is vast heterogeneity in the genotype as well as the phenotype that it expresses. So you can see the same gene can cause multiple phenotypes, and multiple phenotypes can be caused by multiple genes. So it's a very complex kind of scenario. So the first advancement that has come is our understanding of this basic thing, that we are able to do genetic testing and kind of assign the disorders to a particular genotype and tell which genes are causing which type of phenotype. So that is the first advance that started our understanding of these diseases. The limited treatment options at this point are a problem, but that is being solved subsequently. So we can basically divide them into retinal degenerations that affect kind of the whole of the retina, the rods and the cones, or macular degenerations, the macular dystrophies that kind of affect only the central part of the retina. Some of them would be stationary, some of them would be progressive. So options for vision restoration that are being kind of looked at in these disorders. Number one is cell replacement. We have rods and cones that are going away, so we replace them with newer rods and cones, maybe with stem cell therapy. That is something being looked at. Gene therapy is a very vast field that is being looked at, where we are trying to modify the character of the gene expression that is happening. Optogenetics, when we can't kind of make those rods and cones function, we kind of try give those functions to other cells in the retina that are functioning, maybe the bipolar cells. We try and give those functions to those cells. And obviously prosthesis, where you kind of bypass the whole retina which is dystrophic and take the signal directly to the brain. So these are the various treatment modalities that are being looked at for these disorders. So gene therapy is of particular interest because there is advancement going on in this, and retina has long been considered as an ideal target for gene therapy because we are in an immune privileged state in the retina, so it is protected by the blood-retina barrier. There is small amount of tissue that is to be targeted rather than the whole of the body. There are established surgical procedures to reach the site of interest, and we can monitor the response to therapy functionally as well as anatomically with various modalities that we were just talking about. So the advancement started right in 1994 when basically we started to get to know the genetics of these disorders. Genetic testing became available, and now presently in 2023 we have more than 1,000 clinical trials that are ongoing for these disorders. More than 30 of these genes that are being tried to be treated with gene therapy. So it's a long process, yes, so it takes time and takes money, and that is why it's a little costlier process also. So I'm just going to briefly discuss various options that are being tried out in gene therapy. The first one is to augment the gene therapy, augment the gene function. There is a protein that is being malformed or formed less, so we kind of augment that by introducing the correct gene for that, and that is the LCA, that is the RP65 Luxturna that is now FDA approved also, which augments that gene function. The next is gene editing. You have a protein that is being formed that is abnormal. You kind of edit that gene in vitro. This is used for larger genes which cannot be put into viral vectors. So we try and edit the gene in vivo inside the body and try and make it produce the correct protein. Or you can do silencing. You have a protein that is being malformed and that is causing problems rather than solutions. So you kind of try and silence it. And there is a newer form that is gene modification. So that is basically, instead of targeting that particular area, you target pathways that are upstream or downstream and try and modify the response to get a favorable response. So these are the broad concepts that are being thought of, and they are being tried in various clinical trials. Augmentation, I already told about Luxturna that we have. Gene silencing, I think Praveen ma'am talked about AMD genetics, where we are trying that to kind of use gene silencing. Gene editing again is being used in LCA for using the newer CRISPR technology that is there to in vivo edit the genes, and also gene modifications. So there are viral vectors as well as non-viral vectors which are used. Viral vectors are more favorable because they are tissue specific. They can deliver the gene at the target, but then again, because it is a viral vector, there is going to be a inflammatory immune response of the body. So over time, there can be problems related to that. And also there is a limit to the size of the gene that we can kind of edit or replace with these viral vectors. So non-viral vectors are also being looked at, but they are non-specific, so those are the issues that are being taken care of. We can deliver the target by various modalities, but subretinal till now has been the most commonly used. Intravitreal is appealing, but then that exposes the drug to a lot of inflammatory response and then autoimmune response to the drug, and ultimately the effect of the drug goes down. So these are just an update on various trials that are ongoing, and you can see majority of them are in phase 1 and phase 2, but few of them are in phase 3 also, including some for achromatopsia. And so identification of the disease causing genes is the most important. Then comes the development of animal models for those diseases, and where we can test out these vectors, vector selection and development. There is route of delivery that you need to think about, immunogenicity and toxicity, and obviously the cost of development of this therapy. So, but to get to all this, we need to start first identifying these disorders at an early stage. I think that is somewhere we are still lacking. We just kind of label them as dystrophy, heredomacular degeneration, or RP. So we are just kind of labeling them. So even when we have gene therapy, we need to have our own repositories that how many genes, patients with particular genes we have. And as the disease progresses, the chances of gene therapy helping those patients becomes lower and lower. The more atrophy you have, the more lesser cells you have to target with the gene therapy. So it's important to recognize some of these disorders early. So I'm just going to show a few disorders and patients where we can kind of pick up some clinical clinchers and try to identify these disorders early. So this is a young girl who was showing to us ever since about she was 2 years of age, 3 years of age, and just with nystagmus, some sensitivity to light, just being followed up, given glasses, no particular diagnosis could be made. For almost like 4 years we saw this child with, she was just like that. So once we saw this child in 2021, she was referred for suspected to rule out retinal dystrophy. This is the fundus of the child. Anybody would see this and say, yes, this is a kind of a normal fundus. But we just heard about advances in retinal imaging. So if you do fundus autofluorescence for these patients, you can kind of pick up subtle changes in autofluorescence which may not be visible to you. And these are particularly patients who are not very favorable to be seen with an indirect ophthalmoscope. They are very photophobic, and this kind of imaging is helpful in them. And then you can do OCT and pick up this focal defects in the cone layers, and your electrophysiology kind of clinches the diagnosis for you. You have no light adapted responses, but good dark adapted responses. And genetics kind of proves it that this is a case of achromatopsia via CNGB3 mutation. So just like that, a completely reverse scenario to this is Leber's congenital amaurosis. They are photophobic. These children love looking at light. So if you have a child who is the parents say is not seeing, but the child is constantly gazing at your indirect ophthalmoscope light, has a hypermetropic refractive error, kind of pokes the eye with the oculodigital sign, those are signs which are highly suggestive of Leber's congenital amaurosis. Posterior segment, you may not see such frank findings always, but if you see a hypopigmented kind of fundus in very young children, these are early onset retinal dystrophy, so 1 year, 2 year old children, when you see such, they are most likely to be causes of LCA, Leber's congenital amaurosis. And this is the kind of disease that we have the treatment RP65, which is again a form of LCA, a very early onset retinal dystrophy. Some of these disorders are syndromic, so you need to look at the whole patient. This is the kind of fundus we are commonly used to looking at and calling it RP. But if you look at the whole patient, try and diagnose the other disorders that might be associated. There is polydactyly, there is obesity. So this is kind of a Bardet beetle-like picture. Similarly, if you have hearing loss, goes towards Usher syndrome. Again, there is a lot of gene therapy work that is going on in Usher syndrome to treat that ciliopathy. Enhanced S-cone syndrome, I think, is another disorder we most commonly miss, label it as RP with CME. If you see this kind of mid-peripheral distribution of the abnormalities, and that can be better picked up with autofluorescence, and you have sheaths at the posterior pole, this is kind of indicative of enhanced S-cone syndrome. Electrophysiology again clinches the diagnosis in such cases. The patients present with reduced vision at night, but this is not RP, this is enhanced S-cone syndrome. and caused by NR2E3 mutation. And congenital stationary night blindness, again the patient will come to you with complaints of night blindness but near normal visual acuity, and you would actually find nothing on examination. The fundus is normal, the autofluorescence is normal, the OCT will be normal, but once you do the electrophysiology, you know that the patient is not lying. There is no response in the dark adapted 0.01 stimulus, and once you do the higher flashes, you see an electronegative kind of waveform. There is no B wave that is coming that indicates there is a problem with transmission from the photoreceptors to the bipolar cells, and that is very much indicative of congenital stationary night blindness, and you get a good cone response here, so that proves the diagnosis, and you can get genetics and kind of confirm that and counsel the patient that yes, all they need to do is switch on more light. They are not going to progress, they are not going to lose vision, just night blindness is the only problem that they'll have. X-linked retinoschisis again has very varied presentation that we get. They can present with hemorrhage, vitreous veils, or simply with low vision, and often mixed diagnosed as retinal detachment. But if you pick up this subtle cartwheel-like pattern at the posterior pole, OCT kind of proves this. Male child, and OCT can again show you this is a schisis, not a retinal detachment, and genetics can prove it. Again, electrophysiology, you will have an electronegative waveform in this because it's an inner retinal problem. Stargardt's disease, again, I think we pick it up at a later stage when there is a bronze beaten kind of appearance, but at the earlier stages you can have kind of a dull foveal reflex with these characteristic flecks which kind of spare the peripapillary area. So that is very characteristic for Stargardt's disease. And ABCF4 mutations, it is important you don't prescribe these patients multivitamins. The more vitamin A you give to these patients, the faster the progression of the disease. So dark glasses, reducing vitamin A intake is kind of helpful for these patients to prevent progression. And FEVR, I think, is very, very underdiagnosed in our situation. So this is a 12-year-old girl who presented with exotropia complaints in the left eye, only because there is a kind of combined retinal detachment in this eye. But once we saw the other eye, you can see this kind of proliferation and the mid-periphery, which you can miss if you are not dilating and completely seeing the fundus. So this was kind of characteristic for FEVR, and once you see this, examine their parents, this is the mother of the same child. If you can recognize the supranumerary vessels, the straightening of the arcades that it's going, and if you see on FFA, you can see the extent of the avascularity in the periphery in both the eyes. She is 6'6", she has no problems. But this kind of is FEVR, and you need to treat this, treat the child's other eye also, so that that doesn't lose vision. So to conclude, gene therapy is no longer the future in inherited retinal diseases, it's here, and we need to be ready for it. Developing our own database to know our genetic makeup is vital at this stage. A lot of these disorders we get classified as uncertain significance because we don't have our own data. Our genetics is different from what the world genetics is. So the current classification systems only include data that is reported from the Western world. So unless we report our own data, those genes are always going to be classified as uncertain significance and not pathogenic. Early diagnosis will be increasingly important as therapy will be dependent on the stage of the disease that we are treating, and cost-effective approaches will subsequently come up just as in anti-VEGF agents once the use become widespread. Thank you so much.
Thank you, Dr. Simar. We can have the questions later, if any. I'll request Dr. Ajay Kapoor. He will be presenting on recent advances in vitreous surgery. In the meantime, I think it would be wonderful if Dr. Dogra comes up and felicitates his student.
Thank you, Ludhiana Ophthalmological Society, for inviting me for this talk. Though I sincerely believe that this talk, as advances in vitro retina, would have been more suitable for someone from PGI, because as a private practitioner, sometimes we don't have access to the latest advances. I'll try to do my best. Vitreous surgery, has come a very long way from 1970s when Dr. Robert Macular did the first vitreoretina surgery to today. It was considered unsafe, ineffective, and now it is considered very safe, very predictable, with reproducible results, but now it's become very highly technically driven. From 17 gauge, now we have come to 27 gauge presently. I am doing 25 gauge, have not really tried 27 till now. And from 500 cuts per minute now, Alcon is even providing 20,000 cuts per minute. So what are the new technological advances that have seeped into this field? There are advanced vitrectomy machines with newer platforms. These machines are very safe. High-speed cutters, as I already told, up to 20,000 cuts per minute. The usual rate is 5 to 10,000 cuts per minute. The instruments are very small gauge, 25 and 27. And non-contact wide field viewing system from old days of irrigating lenses and Landis lenses. Now we have non-contact wide field viewing systems. And latest is the heads-up surgery, where the surgeon doesn't really need to look down into the microscope. He sees up at the 3D screen. And another is intra-op OCT. So as I was talking about the machines, the three platforms which are almost similar, they are Constellation from Alcon, Stellaris Elite by Bausch & Lomb, and EVA from DORC. Though I think the number of installations of Constellation in this area is much more than the others, and rightly so, because this machine has little upper hand as compared to the other machines, also because of this after-sales service. But these machines are not cheap, they're very expensive, so if you want to have a very safe and good machine, you'll have to spend more. So they provide a very accurate IOP control, unlike the older days where the fluid used to come into the eye through a gravity system. Now you can accurately control the intraocular pressure while operating, and this helps to save the health of the optic nerve later on, because in earlier days we used to see patients landing up with optic atrophy after vitreoretina surgery. This machine has lots of built-in sensors which allow the machine to stop once something is wrong, so the safety factor is enhanced. And these machines support 25 and 27 gauge cutters. These cutters have very small distance from the tip to the cutting edge, and very minimal small entries made into the eye, hence recovery is very faster. And because of this tip, which is the cutting port, which is very close to the tip, these cutters can enter into the various levels, into the various membranes of diabetic retinopathy, making this surgery very safe. And even a single instrument is able to do all kinds of manipulations what we used to do with forceps and scissors. So because of the enhanced fluidics, aspiration and duty cycle of these machines, even at a very high cut rate, the aspiration is not compromised and the surgery becomes very quicker. And again, in spite of the fact that the light is very fine, there is no dearth of light inside the vitreous cavity. Once you are looking, it's very bright and shiny because of the advancement in the lights. So here I will be showing you a little video. This has been provided to me courtesy my friend Dr. Sangeet Mittal from Jalandhar. So here you see this membrane is totally stuck with the retina, and he is doing all this surgery with a single instrument, which is his fine cutter 27G at high speed. The membrane is coming. Since these are very small cutters, they have a very small sphere of influence, and the retina does not jump into the cutter, so iatrogenic breaks are far and few. This is a very complex case. Every vitreoretina surgeon sitting here knows. This is so to do this, accomplish this case, complete it without causing a break is a great feat, I would say. And post-op results are marvelous. So coming back to my presentation, So the next advancement, as I said, was about the viewing systems, peeping into the vitreous cavity. So non-contact wide-angle viewing systems have been around since long now, 20 years. Even I've been using them since 2005. And the latest is the 3D heads-up surgery provided by two companies. Alcon provides, it's known as Ingenuity, and Carl Zeiss is called Artivo. They are, but I believe, good for teaching institutes, not much benefit for a single private practitioner. It is very friendly for the surgeon's neck. However, it is not very friendly for his wallet. They are very expensive systems. So this is what it looks like. The surgeon is looking straight at the 3D system. So if a fellow is operating or a junior or senior resident is operating, his guide mentor can be standing there having the same view and can guide him better. So that's, I think, the major advantage of this system. So OCTI or intraoperative OCT, it provides us with valuable information while we are doing macular surgeries, ERM peelings over the macula or ILM peelings. It helps to distinguish between schisis from detachment, finds a break in the area of TRD in extensive membrane peeling like in diabetic cases where we have not caused any iatrogenic break, but there may be some small pre-existing break, so it can help us to find that. So another surgical interventions are Chandelier-assisted scleral buckling has really not taken up very much. People have not adopted it because old-timers like me who are used to doing scleral buckles with indirect ophthalmoscopy are very happy with that. So fibrin glue is being used by Dr. Mudit Tyagi from LVP for Reg-RD. Gene therapy, Dr. Simmer has very well elaborated. Stem cell therapies are also under trials. And there's another now solution for dealing with surgical aphakia. This is a lens provided by Apasamy known as CMT Flex Foldable Sutureless SFIOL. So here I will be showing you a little video provided by Dr. Mudit. Thanks to him. This glue is used extensively during pterygium surgery. We all know it has two components, a thin and thick component. So after doing complete vitrectomy, settling down the retina by a fluid air exchange. So what he does is he put this glue over the break and no other tamponade like gas or oil is needed and patient positioning is not needed. So this is the break. As you can see, vitrectomy is being done. Fluid air exchange to settle the retina. This is laser around the break, and after the laser he is putting a drop of glue over the break. So then this coagulum is formed which is picking up and putting over the break, and again starts the fluid from the air. No positioning, no tamponade. Intraoperative OCT shows settling of the retina. And this is post-operative. So gene therapy, as Dr. Simmer was just mentioning, Luxturna is the first FDA-approved therapy for treatment of biallelic RPE65 inherited retinal dystrophy. I will not go into detail, he's already mentioned about it. But it is very expensive. I think it's about $850,000 per procedure. So this is a new SFIOL, which I was talking about to deal with surgical aphakia. It is foldable. The technique is sutureless. It is very safe. There is no breakage of haptic or erosion of sutures as seen in other procedures. A short video for this. This is an unedited video, and if somebody wants to, me to delve over one of its part, I will be happy to do so. I'll otherwise just show you the relevant portions. This is my video. So you just mark the cornea 180 degrees, you make 2 points. Limited conjunctival peritomy over it. And after using diathermy, I will be creating 2 partial thickness scleral flaps. With the help of a crescent blade. So now making the flap on the other side. So once the flaps are made, I'll be making 2 entries into the bed of the flap with the help of 23 gauge trocar, like this. Now this is, I'm putting infusion fluid into the eye to maintain the globe. Here is the entry for the forceps to hold the IUL once I'm putting IUL in. This is a 23 gauge trocar. So IUL, I will be just folding the IUL now. .8 mm superior clear corneal entry. So here the first forceps goes into the eye. And here the IUL I'm starting to unfold. It has a T-shaped end at the last, which I'll be grasping with this forceps. First grasp that before unfolding the whole of the IUL. The upper end is being held by a McPherson forceps at the entry point, that is 2.8 mm tunnel. And here I bring out one of the T haptics out. So being a T like this, it gets fixed at your port. It doesn't go in. It's self-holding. And holding now this with another forceps, there will be shake hand technique, and I'll be bringing out the other end. So both the ends are out, I think now. The IUL is stable. So just put the flaps back and put glue over it, and the surgery is over. Has marvelous post-op results. So usually in my hands, I'm usually doing either retrofixated iris claw or this IUL now to deal with surgical aphakia. Thank you very much.
Request Dr. Ravinder Malli to be ready with her talk, that is recent advances in management of uveitis. Meanwhile, I'll request Dr. Dhami and Dr. Neeraj. Sir, please come and felicitate Dr. Ajay.
At the outset, I want to thank Ludhiana Ophthalmological Society and ARC committee for giving me this opportunity. So I'll be covering recent advances in the management of uveitis. Now, this is a vast topic, so it would not be possible to cover all the things, but I'll be touching upon some important points in these headings. And as we'll be talking about the recent advances in the diagnostic part as well as treatment, but we should not forget that the uveitis diagnosis is basically first clinical diagnosis. So you should not forget about the basics. And Sun Group has given us a classification system for standardization of uveitis nomenclature, so that we are able to, after clinical examination, we are able to
categorize uveitis into different categories depending on the characteristic ocular features. So one should be able to identify whether the uveitis is onset is either sudden or insidious, what is the duration, how is the course, whether it is acute, chronic or recurrent, what is the location, is it anterior, intermediate or posterior uveitis, or pan-uveitis when there is involvement of all these three areas. And it has also given us classification of anterior chamber cells and flare. You can go through the classification, you can find out on the on the internet, and it is very beautifully given all the details of diagnostic part. So further classification should be whether it is non-granulomatous or granulomatous, and depending on all these things, we can further see whether these things fit into infectious uveitis or non-infectious uveitis. So basically it gives us a roadmap to diagnose. After naming, meshing, we can pinpoint our diagnosis in certain particular direction, and then accordingly we do the lab diagnosis and particular tests. So I'll be basically covering the OCT biomarkers, which are very useful tool in diagnosis of uveitis, and sometimes we have confusion regarding the clinical features, and this gives us further edge in diagnosis. So it is very important, leakage disease. Now I'll be showing some case examples. She's a 35-year-old female who presented with sudden loss of vision in the left eye, and you can see multiple areas of serous detachments in the posterior pole with disc edema. And on OCT, you can see there is this boggy, RP undulations, and there is serous detachment, and there is a bacillary layer detachment, which is a hallmark of VKH disease on OCT. What is bacillary layer detachment? It is basically the splitting of the myoid zone of photoreceptors, and this gives us sometimes we confuse these patients with bullous CSR kind of patients, and once you see these septae and bacillary layer detachment along with serous detachment, you are very sure that it is inflammatory, and also you see hyperreflective dots also. So the lower OCT is showing the OCT of the disc, showing disc edema. And in this OCT, it is even further more clear. And on angiography, you can see multiple areas of pinpoint hyperfluorescence which leak and pool in the later phase, leading to multiple hyperfluorescent areas of leakage. So this is how the patient presented, and then was instituted with oral steroids followed by immunosuppressive therapy, and she is improving. OCT angiography also gives us clues regarding the choriocapillaries. In this, there is involvement of the choriocapillaries, and there are granuloma formation. So in the disease phase, you can't see the details of the choriocapillaries, and once there is improvement with the treatment, the normal architecture is restored, and you can even follow up on OCT angiography to see the choroidal thickness coming back to normal, and it can be used in overall monitoring of the disease. This is how the patient improved over a period of time. And this is another patient. She is a 22-year-old female. She was pregnant, and in the second trimester of pregnancy, came with sudden loss of vision. You can see there is a juxtafoveal yellowish lesion with serous detachment, and there were hardly any cells, and this was a OCT, and you can see there is increased size of the choroidal vessels, and there is subretinal hyperreflective material, and with serous RD and subretinal hemorrhage. Now in this case, the OCT angiography gives us a very important clue. Now you can see there is such a good, nice choroidal neovascular membrane net, which you can identify on OCT angio, and that changes the management. Now we are going to treat this patient with the anti-VEGF agent. Already I've treated her with eccentrics, and this is just few days old. But these patients now we can say that this is most probably she was having punctate inner choroidopathy, which is most of these patients develop choroidal neovascular membrane, and these are very difficult to treat. They keep on having recurrences, and many of these patients need immunosuppression. So after pregnancy, maybe after some time, she might need Ozurdex implant if there is recurrence of this lesion. And another patient, she was also similar type of presentation, and she had sarcoid type of uveitis initially, and then she presented with the juxtafoveal yellowish lesion with the CNVM. This was in 22, and the CNVM regressed. Now, after 2 years after COVID, she stopped the immunosuppression and she came with recurrence. Again, she has been treated with intravitreal anti-VEGF and oral immunosuppression. In Behçet's disease, now this is a patient who is a 25-year-old male presented with bilateral non-granulomatous uveitis. I want to actually show all these features which are very, very typical of Behçet's disease. Now, he presented with the non-granulomatous uveitis with a streak hypopyon in both eyes. There was severe vitritis, disc edema, retinal infiltrate, superficial retinitis patches, another patch of retinitis with some hemorrhages, and serous detachment. And most importantly, inferiorly, you can see these pre-retinal aggregates. These can also form posterior hypopyon also, and in the other eye also, it was the same picture. Now, angiography gives us the clue. There is a diffuse fun type of leakage in both eyes, extensive vasculitis, and in this OCT pictures, okay. So, based on just the fundus picture, we can say that this is a patient with bilateral non-granulomatous panuveitis with shifting hypopyon with vitritis, retinitis, vasculitis, pre-retinal exudation, retinal infiltrates, neuroretinitis, disc edema, CME. He had everything. Along with that, he had skin lesions. There were no oral or genital lesions. So you can pinpoint your diagnosis towards Behçet's disease. Now, further OCT helps us in further diagnosis. Now, in this, you can see there is a hyperreflectivity of the inner retinal layers. These are the vitreous cells, serous detachment. Now, there is more involvement of the inner retinal layers. As compared to VKH, this is the picture of VKH where you have more involvement of the choroid than retina, and there are choroidal granulomas and lumpy undulations with outer retinal involvement. In this Behçet's, it is the inner retinal involvement, and you can see there's choroidal vasculature is almost well preserved. So this is neuroretinitis along with the retinal findings. And on angiography, the choriocapillaries are well preserved. And this is how the patient improved after IV methylprednisolone and with the institution of immunosuppressive therapy. Nowadays, recent treatment of these patients is with biologics, because this is a disease which recurs and it is a very bad prognosis. So these have to be on long-term treatment, and this is best response to biologic if patient can afford. Another patient, she also had, now you can see the right eye, she has already lost because of uveitis, panuveitis, and she presented in the left eye with non-granulomatous uveitis. At the first go, we can think of that whether it is a sympathetic ophthalmia, because the way she presented was decreased vision with vitritis and serous detachment. She was treated with steroids, and but the picture was not suggestive of sympathetic ophthalmia. It was more like a Behçet's type. But after some, and you can see the vasculitis here. And after some time, when we decreased the steroids, she recurred with a lot of new lesions. You can see the area of retinitis, severe vasculitis. Now, OCT helped in the diagnosis. You can see the OCT passing through this area shows the hyperreflectivity of the inner retinal layers with shadowing of the posterior layers. So this is very, very typical of Behçet's disease. And there is a superficial membrane formation, and this is how the patient improved with medication, with the immunosuppression and steroids. She was treated with Ozurdex implant also to decrease the load of steroids. And this is how she is after on the last follow-up. Just few more patients. This is a patient of syphilitic retinitis. You can see there is a serpiginous kind of involvement, and initially no test came positive, and he was started on steroids, but after some time he started having these punctate raised lesions in the periphery at the advancing border. And in this OCT gives us clue there was diffuse RP granularity in the OCT. I have somehow missed that OCT on this slide. And that gave us clue to the ocular syphilis. Another patient of syphilis with bilateral optic disc edema with now angiography showing diffuse leakage on angio, and you can see small punctate chorioretinal spots inferiorly, and he had all the features of syphilis, skin lesions and all, and he was treated with the specific treatment and became all right. In toxoplasma, now you can see this is a young patient with the acquired toxoplasma chorioretinitis, intense yellow lesion, satellite and fog appearance most of the times, but OCT, if you do on the lesion, you can see there is hyperreflectivity of the retina with shadowing of the inner layers and the posterior hyaloid thickening with the pre-retinal exudates. I will not cover posterior vitreoretinal lymphoma, primary vitreoretinal lymphoma, that also has a typical appearance. And these are the tubercular uveitis, typical pattern, serpiginous like choroiditis, another patient showing paradoxical reaction treated with steroids, and TB vasculitis presenting with pan-uveitis. So sarcoidosis with candle wax drippings. Angiography gives us the diagnosis. And now the challenges are basically how to reduce the load of steroids. So these days we try to give the local therapy wherever possible after ruling out the infectious disease. And I think that would make a long, maybe I will take more time. So I'll just finish with two more slides. So with the latest treatment modalities, what we these days prefer is biologics as a first line in treatment of juvenile idiopathic arthritis and in Behçet's disease. And IOL should not be implanted in patients with JIA. Over a long period of time, they show hypotony and cyclitic membrane formation. So that is the new thing in JIA. And this is another area which is coming up, that is gut microbiome. Whenever there is a dysbiosis in the gut microbiome, that can lead to exacerbation of uveitis, especially HLA-B27 related. So there is a new treatment, new research is being done in this field. So to conclude, with the continued advancement of the diagnostic techniques and the targeted therapy, there is early identification and rapid inflammatory control has been increasingly become possible, and new therapies with long-lasting drug injections as alternative to steroids and for altering the immune status are being developed. Thank you.
Thank you so much, Dr. Ravinder. I'll be requesting Dr. Saveen to come up now with his talk, which is recent advances in treatment of posterior segment trauma. In the meantime, I will request Dr. Rajvinder. Ma'am, please kindly come up on stage to felicitate Dr. Ravinder. We are doing pretty well with our timing, although we were almost about half an hour, 45 minutes late in the beginning, but we've covered up most of the time. We have two more talks. So Dr. Saveen, after that, Dr. Neeraj, I hope you're ready with your talk.
इसकी ज़रूरत नहीं है, उसकी ज़रूरत नहीं, ऑडियो मतलब क्या जाएगा। पेन ड्राइव में है तो दे दो, उसको टाइम लगेगा, पेन ड्राइव में तो है नहीं, पेन ड्राइव चाहिए। Sorry for the delay. Good afternoon, everyone. First, I would like to thank Laws for having me here. I'll be talking on surgical management of posterior segment trauma. Ludhiana being an industrial city, we oftenly encounter cases of intraocular foreign bodies. So this presentation will be all about its management. Whenever we get such a case, certain doubts always pops up in our mind. Doubts like whether to do the primary repair first and then deal with the foreign body in the second sitting, or plan a single sitting management. Whether I should go for lensectomy or do a cataract extraction using a phacoaspiration. The decision of the route of foreign body removal is always been tricky. Whether to induce PVD or not, whether to put an IL or not, and finally, when to use the tamponade. So in this presentation, I'll be discussing my thought process in managing such cases with the help of few surgical videos and clarify these doubts. Coming to the first doubt, whenever we have a sharp, linear corneal tear with regular edges with uniplanar configuration, as we can see here, suturing such wounds, we know that we can achieve a very well-sealed anterior chamber. Such cases can be planned in a single sitting. The foreign body can be removed that way. In contrast to cases with a bad multiplanar wounds where the tight closure is not possible and cornea is not that very clear, we should reserve it for the second sitting. Like here, it's a very bad wound. I did the primary repair, and 2 weeks later, we can see the very clear cornea. Wound is very stable, and we can plan the foreign body for the later. Now, lensectomy or phacoaspiration decision, it depends upon the injury to the anterior capsule. A very small tear in the anterior capsule with the cortex that is not very fluffy, there, phacoaspiration is my choice, as I can save much of the anterior lens capsule to implant the secondary IOL in the sulcus in the later stages. Large tear in the capsule or a subluxated lens, or sometimes we get a large fluffy cortex that is protruding out of the posterior bag, there lensectomy is the better choice. But we have to make sure that all lens matter is moved, because any residual lens matter can cause post-op inflammation and can lead to trouble. Now, PVD should never be induced before foreign body removal. It saves a lot of vitreous, which acts as a cushion for the retina and prevents its damage. So if ever the foreign body falls back to the retina while removing. just a little bit of co-vitrectomy is done and foreign body is mobilized. Like in this case, the foreign body is already in the vitreous cavity. We can remove it using an endomagnet. Sometimes we get an impacted foreign body which is often covered with a fibrotic capsule there. We need to mobilize it first using a cutter. Cut with the cutter, like in this case with the cutter, we cut the interior capsule of this fibrotic membrane and then mobilize it using a cutter and forceps, and then it is finally removed. Now shape and the size of foreign body helps in determining the route of its removal. For long and elongated foreign bodies like a wire or a plate, scleral route is the best technique. But 2 points here I want to highlight here. The first, the scleral wound for the removal should be parallel to the limbus. It should not be perpendicular, otherwise it will extend posteriorly and cause a retinal tear. And second thing is, we should always clear the vitreous below the scleral wound, because while removing the foreign body like I'm doing here, the vitreous will pop out of this scleral wound and can lead to dialysis. So we should remove it. If the posterior capsule is not intact, then foreign body can be brought up into the interior chamber, make it rest over the iris, and then the smaller and the more regular ones can be removed through a corneal incision, and the larger and the irregular ones can be removed through a sclerocorneal route. But my preferred method is never been a corneal, because it can induce a lot of astigmatism, so visual rehabilitation is very poor. Instead, sclerocorneal route is the best method, because we can easily remove even the larger foreign bodies. Like in this case, look at the size of the foreign body, how irregular it is it can be easily removed through this sclerocorneal wound, with inducing less of astigmatism. And secondly, this scleral wound can be used to implant an IOL in the later stages, in the other surgery, in the next stage surgery. Now here we just press the lip, a posterior lip, and then the whole foreign body can be removed from the sclerocorneal route. Now coming to the tamponade. Now first, when the foreign body is removed, you look at the retina. If the retina is fine, there's no bleeding, there's no break, then don't induce PVD, just close the case. But if there is bleeding is there, or there is a retinal whitening, or you can see a break, then PVD should be induced. The PVD induction should be very gentle. Look at the whitening that is there. If we induce a PVD in a very harsh way, it can rip off the retina from this whitening area, because the retina is very friable over there. So it has to be very gentle. After doing vitrectomy, you need to base shave. While doing base shaving, inferiorly you encounter a blood-tinged vitreous. So always start your base shaving from the clearer part of the vitreous, extend it to the area where there is bleeding, so that you know the exact position of the retina where it actually lies. It will prevent the iatrogenic breaks. Now I have specifically mentioned this case because you can see there periphery there is a whitening over there. Whenever I come across such cases, I prefer to use a tamponade even if the break is not there, because there is subtle breaks that are always present, and or if the break is not there, it can form a month later due to the atrophic holes that are formed, so it can lead to detachment. So I prefer to put a tamponade. Gas or oil, it will depend upon the location of this whitening. If it is superior, then again the gas can be used, otherwise the oil is the best method. Now coming to my last video, this was a case of intraocular foreign body. Patient had a corneal tear with hypopyon and a cataract, and there was a foreign body lying in the vitreous cavity along with a lot of vitreous exudates. So I did a lensectomy for this patient, and before doing lensectomy, I took a vitreous biopsy, because I didn't start my infusion because I didn't want the vitreous biopsy sample should be diluted with the water, and it will affect the outcome. So after doing lensectomy, I removed the foreign body. That's what I'm doing here after doing a little bit of co-vitrectomy through the scleral route. And once it is removed, then we need to tackle now the endophthalmitis part. Whenever I get endophthalmitis, I try to induce PVT as far as possible. In this case also, I know the vitreous was very strongly adhered, but I tried to lift the PVD. I got a little bit of PVD induction around the disc. I debugged the whole of the vitreous, because by doing so, when we put antibiotics, it goes at the interface between the retina and the vitreous. It's the place where the bacteria is usually lies over there. So it gives a beautiful result if you induce a PVD. Since I was not sure whether the foreign body has induced any break or not, so I have inserted oil in this case. After putting an oil, I gave him the antibiotic as well as DEXA in this case, because it was 2 days history was there, so I was not suspecting fungal, so I have given DEXA. 2 weeks later, this was the picture, all infection was gone, but to patient's bad luck, patient developed RD. I took again this patient, this time I did a buckle, belt buckle, and then vitrectomy was done. Belt buckle because I was sure I'll not be able to induce PVD till the end, so this buckle will give me an additional support. Note, then the patient was closed under oil. Patient did very well. After 3 months, again, this is the post-op picture. 3 months later, I planned a third surgery where the oil was removed and secondary implantation in the sulcus was done, and patient did marvelously. After all these 3 surgeries, after 4 months, patient improved to 612. So my here point is, this video I have specifically put is, don't be in a rush to put an IOL in the first sitting, because of the reason, first, the calculation of IOL becomes very difficult when you have a flat AC. We do calculations by seeing the other eye. And second thing is, if at all RD happens, like in this case, it will be very difficult to manage with the IOL in situ. So always make sure your retina is fine, then only go for IOL implantation. Thank you.
Coming to the last talk of our sessions for today, Dr. Neeraj. And in the meanwhile, I request Dr. Sudhir, sir, please come up on stage and felicitate our speaker. Dr. Neeraj is speaking on visual rehabilitation in low vision patients.
Hello everyone. My topic is slightly off the beat, and that is the whole idea. I want you to know that this is low vision care is very much a part of eye care, and we should not segregate it from general ophthalmology. It is an honor indeed to speak in front of stalwarts like Dr. Dogra, Dr. Dhami, Dr. Sudhir, and Dr. Dinesh here. So coming to my talk, there are certain important points we should remember. First is that visual input is a major source of information. It is concrete, it gives overviews, shows processes, and it is easy to store in memory. So definitely reduced vision means reduced information, which has impact on all the 10 degrees from the point of fixation. But the most important point is he uses or is potentially able to use this residual vision for planning or execution of a task. If you look at the global figures, the number of low vision patients is almost 3 times the number of blind people. Globally, if there are 45 million blind people, the low vision patients is an additional 135 million. So it is a very large segment of patients we have to tackle. While low vision care, I'll again emphasize that the basic skills of low vision, they are part of eye care. And the knowledge of low vision, it enhances our understanding of disease consequences and the patient's complaints. It increases the effectiveness of medical, surgical, and optical rehabilitation. As an ophthalmologist, we must understand what is the role of ophthalmology in low vision care. We should be able to identify low vision patients. We should be able to assess patients' functional impairment and to take a practical approach to various low vision devices. And modern low vision assessment is not a mystery. It follows the same standard model of ocular examination, but with evaluation of patient's performance. So task-related history is something which is very, very important in low vision patients, apart from the regular ocular history. Now, apart from visual acuity, there are certain other things which we need to measure before we prescribe a low vision device. They include contrast sensitivity, glare testing, visual field testing, color vision testing, and if available, scanning laser ophthalmoscope and potential acuity meter.
Coming briefly to low vision devices, I won't go into too much details, but basically low vision devices are in two different categories, optical and non-optical. And the fundamental instrumentation in all these devices is adjustment of magnification, illumination, and contrast. Optical devices can be, these are the basic optical devices, which can be in the form of hand magnifier, spectacles, stand magnifier, or telescopes. Now, each of these optical devices have their own advantages and disadvantages, which is beyond the time permitted, so I cannot go into those. And then we have something called electronic magnification, which utilizes a camera and a zoom lens, and it electronically projects the image on the monitor. Now, this has its advantages that it converts any material to a large size print instantly. Binocularity is maintained and it gives a wider field of view. However, it is non-portable and a bit expensive. Now, various types of lenses, absorptive lenses, are incorporated depending upon the patient's needs, which can be the tinted spectacles, photochromatic, filter lenses, tinted contact lenses. And recently, we have been able to use telemicroscope and night vision aids, which are generally used by defense personnel as a form of low vision aids. Now, there are lots of non-optical aids available, which they just supplement the optical aids, and they are basically help you to sign a document or write a letter. Bold line notebooks are very useful in children, along with felt tip pens. Now, there are lots of developments recently. Those were the basic devices which I just talked. There are lots of developments recently which have brought technology into low vision aids, which is very much evident in the devices and equipment which is used by the patients these days and in assessment tools. And these developments have brought major changes in the way individuals with partial sight confront visual impairment. Unfortunately, most of these high-tech devices are not available in this part of the country. Beyond Delhi, yes, I know in where I did my fellowship, LV Prasad, Hyderabad, they have lots of low vision devices, the latest ones, and but not here. Now, the design and quality of spectacles and magnifiers have recently improved drastically, providing larger field with minimal distortion at higher power. Now we have thinner, high-index lenses available, which are much more acceptable functionally and cosmetically. Even the telescopes have become smaller and lighter, so the ease of use has increased. And autofocus technology, which is not yet available, but it soon should be available in the low vision care. The most promising technologies have emerged in the field of electronic and computer devices, mainly because this generation of low vision patients is much more familiar with cell phones, ATMs, computers, video conferencing, and internet. So they will more easily integrate these devices currently being developed and challenge providers of ophthalmic low vision care with ideas of customized software. So there are certain things we must remember, that multi-handicaps should be paid more attention. We must always, in case of children, we must always try so as a child is able to cope up in a normal school. So the fellow children should be made to understand the child's problem. The proper lighting and contrast in the classroom should be ensured. We must avoid a situation where a child has a feeling of helplessness, hopelessness, isolation, and depression. And the involvement of family members is again very important, so that they understand the patient's abilities and deficits. We must discourage the common myths. Using too much eyes can cause the current problem. Using too much can damage the remaining vision. Now, most of the patients feel the holding material too close is harmful. It is not. Because most of these low vision devices, they require you to hold the reading material close to the eyes, and which is not harmful to the eyes. Sitting close to TV is dangerous. It is not as far as low vision patients is concerned. Regular examination is not required if there is an irreversible condition. So to conclude, any patient with impaired functional vision by definition is a low vision patient. Increased awareness and knowledge both among the patient and eye care providers is necessary. Training of low vision and rehabilitation should be part of basic training of residents, which unfortunately is not, at least in this part of the country. So most of the principles used during low vision assessment and management, they easily integrate into routine ophthalmic practice. Ophthalmologists therefore have an opportunity to practice low vision care every day and should take into account, in addition to medical and surgical strategies, optical and rehabilitative strategies. Sorry, I need to go back once. So all professionals who are confronted with people with severe visual problems should have good knowledge of many different forms of low vision devices and of the broad scale of helpful devices and supportive conditions. Thank you.
Thank you, Dr. Neeraj. I'll request Dr. Rana, team member, kindly come and felicitate Dr. Neeraj. At the same time, if there are any questions that we have in the audience, no? All right. On behalf of the organizing committee, I'll be calling Dr. Rana to give the official vote of thanks. But before that, all three of us would really like to thank Dr. Dinesh Garg and Dr. G.S. Dhami for all their help and support in organizing this event. Thank you, Dr. Parveen Sen, for updating the WhatsApp group every 5-7 minutes. The certificates are all available outside, all signed and duly attested by the PMC representative. Please collect it from the registration counter. Thank you so much. I think we have finished on time. And now over to Dr. B.S. Rana.
Good afternoon, everyone. On behalf of Ludhiana Ophthalmological Society, I would like to extend my heartfelt gratitude to each and every one of you for gracing us with your presence at Retina for All event. It has been an enlightening and enriching experience for all of us, filled with insightful discussion and valuable exchange of knowledge. I would like to express our sincere appreciation to all the distinguished speakers and experts who generously shared their expertise and insights on various aspects of retinal diseases and treatments. Your contributions have truly enriched our understanding and will undoubtedly benefit our practice in field of ophthalmology. Special thanks to Dr. M.R. Dogra, whose pioneering work in retinopathy of prematurity has significantly advanced our understanding and treatment of this critical condition. We are deeply grateful for Dr. Prashant as representative of AIUS ARC for gracing the event, and I hope they will continue to organize more such events like this. I would also like to extend our gratitude to entire LOS team, especially Dr. Nitin Batra, Dr. Neeraj, all CMC guys. I would like to thank Dr. Dinesh, Dr. Dhami. Without your support and assistance, this event would have not been possible. Last but not the least, I would like to thank each and every attendee for your active participation and engagement throughout the event. Your enthusiasm and commitment to the advancing knowledge in field of ophthalmology are truly commendable. Thank you once again, and we look forward to your continued support and participation in future endeavors. Thank you.
There is just one small thing. I request Dr. Dhami sir, please come up on stage. Dr. Dinesh, Dr. Rana, myself, and Dr. Neeraj would just like to thank you.
And I think before we finish, we need to felicitate Dr. Nitin Batra, who has been tirelessly working behind the scenes for last more than a month. Yeah. Because I think he is the Sachin Tendulkar of our LOS, isn't it? Dr. Karamjit, ਤੁਸੀਂ ਵੀ ਆਓ please. एक मिनट यार, डॉक्टर करमजीत आ रहे. And we must also thank the postgraduates of Christian Medical College, Ludhiana. I don't know how to thank them personally, but yeah. And the sponsors for this event. Thanks a lot for extending that support. Without the involvement of trade, none of these CMEs are possible. And I think we all joined for lunch. Thanks.